firstly to say what Australia learned from other countries, particularly Europe and Canada and US, and what we got from our people who are diagnosed with dementia regarding the key contact after their diagnosis. Dementia diagnosis in Australia is probably like everywhere facing different issues, and we still can't say that we have totally timely diagnosis, but we are getting better. And as many of you following what is happening in the world of medications, and also the blood test for early diagnosis of dementia, it is clear that we all need to work hard and to be able to use the blood test for early diagnosis, and also to start as soon as possible with the medications that can be effective only in early stages of dementia. Dementia is a serious issue in Australia because this is the first leading cause of death for women and the second cause of death for general populations. The diagnosis of dementia can be obtained in memory clinics. In Australia, we have around 150 memory clinics, which are part of Australian Dementia Network memory clinics. We also have geriatricians' offices in public and in private sectors, neurologists, particularly if dementia is more complex, and also we have cases of younger onset dementia. In Australia, we have 28,000 people diagnosed with dementia in the age below 65. And we are trying, particularly according to the models that we can see in Canada and US and part of the Europe, to also educate our general practice medical professionals and to get the diagnosis in general practice, although in Australia it's still not very often. But what happens when someone is diagnosed with dementia? For some of the people, it is relief because they know that the symptoms that they had and everything that they feel, it's not as it was before. It is something that worried them, and the diagnosis can be relief. Okay, I know finally what is happening with me. But what most of the people, this is shock. This is something that immediately produce the thoughts about very bad life with no independence, with no driving, and probably lack of socialization and many other things that immediately, when we know that we are losing our mind and we are losing our abilities to comprehend and talk and walk and be functional for everyday life, it is very scary. And we know from the literature that it is very important to have a good post-diagnostic support. But in Australia, still, in the memory clinics, particularly in Victoria, that they firstly designed the memory clinics, and they already have very good network. They have one session after the diagnosis, and they produced the package of information relating to their future life. In other memory clinics, as we form dementia network guide for the memory clinics, we can see also that it is improving according to the information. But usually it's still information, verbal or written. If it's written, it can be too much, and people really do not know what is the purposes of all information that they got. And many of them, through the research we found, just put the package with the information and don't see that again, because this is something that scared them in a way. We have a few organizations that are very good, and particularly Alzheimer's Association, which is now Dementia Australia, functioning for many, many years. Also, Dementia Support Australia is another huge organization that provides support. But as people are not linking immediately with their diagnosis, they probably do not contact, many of them, of course, some of the people contact that organization, and their life looks a bit different. But many of people just can't navigate through the information, and also many of them do not get written information. It's only verbal, and who can, with memory impairment, recall all that information that they got? Even carers or family member who is supporting the person with dementia, it is difficult to know what the doctor suggested. Many of them, after seeing memory clinic, doctors, neurologists, or geriatrician, or in any other places, neurologists or geriatrician, are returned to their GPs, and GP got report about just some of the services or possibilities of cognitive stimulation therapy, but it's also happen very rarely. And usually the only of the care that they got is the three types of medications that we have now, three types of cholinesterase inhibitors, or another medication, memantine or Namenda. It's depend of the generic names. So probably for everyone, you heard for that. And in Australia, still none of the three medications that are approved by Food and Drug Administration in America in last 3 years, none of that is approved in Australia. So it's very limited opportunities with the pharmacological therapies, and almost nothing from non-pharmacological, and a bit of support from national organizations if they are able to call the organization. So we try to find more from our people who are diagnosed here, what for them is very important. And this is something that led us to the point of dementia manager, dementia coordinator, or case manager role. Because through the interviews with people with dementia and carers who are just diagnosed with dementia, we included in our research people who are diagnosed in the previous 1 year. So the diagnosis needs to be recent. And also we included health professionals who are involved in dementia diagnosis. So from them, we learn what will be very important for people to get after dementia diagnosis. And we got the funding that I will not share in total. I will share only what is important for my topic. But this topic was the strongest advocated topics through the interviews with people with dementia and carers, and also through the focus groups and expert panel meetings with health professionals. They told us that information needs to be much more clear and succinct, that it needs to be use pictures or infographics in the explanation of their services and what is appropriate for them at that time. They need to get immediately education about dementia prognosis stages and what is characteristic for which stage. And they need to get counseling, if it's possible, some therapy for cognitive stimulation, exercise, or all other non-pharmacological therapies that exist. So probably they need to be linked to allied health specialists. But the main point is a central point of their support that is called in literature case manager, and some of the people call that key support worker or link worker or coordinating manager. We have different names for that. And also through our research, we got different names. But it is important that when you are diagnosed with dementia, you immediately assign for your case manager, call that like case manager at the moment until we don't have the real name. But yeah, case manager should be a person that is accessible, available, and that can provide continuity and also navigation, coordination, and advice since the diagnosis is obtained until the end of the life. So it is something that we got from Australian people, and also after that we'll look at the literature. And in the literature, particularly in Europe, we found many different titles for this role. We got Admiral Nurse, Dementia Advisor, Key link worker, intensive case manager, link case manager. So different names, even from the UK, we have different names. And also in Netherlands, we have two types of managers. So this is something that on the slide you can see how different names are used for that central point for communication, coordination, and support. In Canada, they have done a lot of work with primary practice manager for people with dementia, and they also diagnosed people in primary practice. So their GPs are doing some work relating to this role. And also they have care navigators, and care navigators can refer like more about the navigation through the services, through the health system, through aged care system. But also the navigators in Canada and America, they can be part of different post-diagnostic support models, but usually the characteristics are very similar, even characteristics with different roles in Europe are similar, because everywhere it is focused to center person care and tailored post-diagnostic support according to the needs of a person with dementia and needs of the carer or family member who is a primary support person. And even in Europe, in England, we have a long tradition of Admiral Nurse management, which was designed primarily for carers and families. So it's family centered, but they also support a person with dementia and try to alleviate their life and help them to find the person in their life. So it is clear that from all different models of case management and different role titles, we learn that a few very important characteristics. So from that knowledge, we go further and we designed a survey asking about characteristics of this role, role title, organizational settings where the role needs to be placed, about the personal characteristics, because we learned that personal characteristics of a case manager or any that kind of role are very important. About the qualifications, we ask also about the training, and we got very interesting results. So in our survey, also, we try to follow a few guides when anything new and innovative in dementia field and dementia research needs to be produced. So we learned that we need to include different populations, but all in a way experts in dementia field. So we include living experience experts, people with dementia and carers. We include people who are working with them, health professionals. We included also researchers because in a way they are also working with them, and they are a mediator between that field in the practice and theoretical framework and policy people. And at the end, we also included policy people who are focused on dementia field and dementia innovations. So in our survey, we got 43 health professionals, 10 researchers, 9 people with dementia, 13 carers, and 4 policymakers. The average age of participants was 53, the range 27 to 82. We have two-thirds women, and this is usually the case in all research. We always got more women than men, and also health professionals are more women. So this is something that we couldn't change. And in this slide, you can see this is a bit busy slide, but I will try to just concentrate on the main point. We ask about care provided. What kind of care? Should be just medical? Should be just health, or both? And we got clearly that it needs to go far away from only health care. It needs to be psychological, and it needs to be social. So the person who will provide that service and who will be in that role needs to have a good knowledge from health, psychology, and social services, or eventually needs to be trained. We will come to this part. Also, we ask about different coordination and managers, and we got that it is very important to coordinate and manage and facilitate access to aged care or disability services if the people are younger and below 65. That person needs to respond to the queries and changes. That person needs to monitor their disease progression, and that they need to provide individual and tailored strategies, and also provide group and individual education. That was for the most important characteristics, and we asked for many more. Some of them had qualitative comments that they said, look, everything is important. All of this is important, and it makes sense, but it depends on the needs of the person. So the person in the role of a case manager shouldn't be stick to just 4 main characteristics or features. It needs to be flexible and person-centered and family-centered. Qualification for the role in Australia, we have a study, a bachelor study for dementia care, and that study include health subjects and social subjects, psychological subjects, and also neuroscience. There are several units about brain and about neurology and about other illnesses. So it was a bit surprised that dementia care specialists who finished Bachelor of Dementia Care got 63%, and registered nurses was the next one, but only 13%. But if you have country that you know that you have the education for dementia specialists, and education that for 3 years provide very person-centered approach to dementia care, it wasn't so surprisingly. Everyone thought 95% that the training is very important. So even with the qualification on dementia care specialist, they need to have the training. And through our workshops, we found more about what kind of training they need to have. Organizational settings, it was difficult to decide for people. Some people thought that it should be memory clinics, another that it should be community, that it should be Dementia Australia. It was very near in percentages. Only hospitals got much lower, only 9%. But between community, Dementia Australia, memory clinics, and general practice, it wasn't it was difficult to say what people really want. Duration of the role, 51% say that it should be according to the client's needs, and the qualitative comments added that even person with dementia died, if carer is still alive, carer needs to get support until the carer thinks that it is important for her or him, doesn't matter. But it should be according to the needs of both person with dementia and carers. Most of the people thought that role needs to be government funded. Most of the people also thought that ability to build relationship and partnership with the family, with the person with dementia and carers, and in another way with the health system, with the aged care system, with the disability system, it is very important. That role needs to have a very good network. And that's ability, although we are talking now on a personal level, but that person needs to have that, along with the communication skills and ability to identify problems and ability to listen and understand people. So this is the main result from our survey. After that, we organized 2 co-designing workshops, and it was it was with the aim, firstly, to better understand the results and outcomes that we got from the survey, and also to get maybe something new through the discussions, because again, we included the same people just in a smaller number, but we have in each of the workshops around 20 participants, and half of them been living experience experts. And we organized that was online workshops through Zoom, but we organized that we gave firstly the right for the voice to people with dementia and carers, and after that health professionals, researcher, and policymaker got their time, but we've been all together and discussed all together. And the principle was, firstly, to really listen to someone who is a consumer of that service, who is a person that we want to make a service according to their needs. So we got, again, interesting data. Some of the results and outcomes from the survey were just confirmed, and some no. So I know that I have 2 more minutes, and this is, I have only 1 more slide. So hopefully we will be okay. Type of care, of course, it needs to go beyond medical care. So it is the same like in the survey. The care participants, it should be primarily person with dementia, but it's also matter of time. They said that during the journey of dementia, and particularly with the last stages, carer may need more support than the person. So again, the role needs to have a lot of flexibility and follow the needs of both. Characteristics of the role, they said everything that is listed, it should be included in the role descriptions, but with a huge, big letters saying that the role needs to be person-centered, family-centered, and tailored according to the needs of people with dementia and carers. Organizational settings, we came to the point that where people are diagnosed, they need to have their case manager there. If it's not possible, like with the primary practice, primary or GP needs to have a link and know where they need to refer the people from there who are without a case manager. So that's one of the solutions how may that problem could be resolved. And duration of the service, of course, until the end of the life, until the end of their needs. And for both, it doesn't matter how their life is going. They always need to have a possibility of continuation and call their case manager and eventually see them. Qualifications, many people talk about Bachelor of Dementia Care, and many participants got 1 year of this like diploma in dementia. So they had some information about the course and they thought that this is the best qualification. But again, the training is necessary and the training needs to have including counseling. That was one of the most important things. And title of the role, we got again different titles: dementia support practitioner, dementia support navigator, dementia support advisor. The main thing is people thought that the role title needs to have dementia included in as a term because this is the way to fight the stigma of dementia. And it is important to know that this is role for people with dementia and carers. Personal characteristics, we got additional like empathy, listening, understanding, but definitely like a gold standard should be an empathetic person with the good skills for listening and understanding and a knowledgeable person. So this is all. This is my reference.
I noticed that this session has quite a few people from Australia, and I guess that's because it's 4 a.m. in London, and it's after 5 in New Zealand. So this is a worldwide global event, and I'm very grateful to be able to be part of it. I would like to begin my talk by acknowledging the traditional owners of the lands from which I am coming from in Melbourne, Victoria. The Wurundjeri people of the Kulin Nation, and acknowledge their elders past and present and emerging. I would also like to acknowledge other Aboriginal or Torres Strait Islanders who may be present today and listening, but I also would like to acknowledge Indigenous people worldwide. Indigenous people have suffered the loss of language, loss of lands, and loss of loved ones. And this talk is partly inspired from an understanding of the need to engage with Indigenous languages, as well as recognise that in the language of neuroscience, we have moved away from one of the key ideas of Darwin. That's the abstract. I won't repeat that. The key points that I'd like to make today are that language has evolved to be the means of reproduction of humans, that science has evolved to study skin-encased bodies, and the clinical practice is built from the study of adult individuals. Economics and politics preference male individuals. Individualism threatens world peace and climate change. And we need new interpersonal metaphors that recognise the millennia of human language. I'm going to do this process by looking at some of Freud's work, some of Bowlby's work, Dan Siegel's work, Susan Greenfield, and a paediatrician from Sydney called Kasia Klotzlowska, who is Polish by background. All approaches can be explained through relating and language. Neuroscience documents mediators, not causal agents, and we are often forgetful of this. Neuroscience has failed to recognise that for all the mapping of the human nervous system, the human body is not independent of its environment. Without the descriptive systems of neuroscience, our understanding of how each body functions will be impossible. But bodies function in interaction with other bodies and cannot survive without such interaction and interdependency, especially across generations. Their interaction happens through language and coordinated by language. Humans are so immersed in language that, as with air, we have failed to recognise its significance for life as we know it. The evolution of biological science has happened through observation of bodies and isolation from others. Within neuroscience, this has meant that they've tended to focus on singular entities, nerves, brain structures, biochemistry, and these are treated largely as independent processes. However, when we start to observe these processes, we have to note that there are distortions of observations that are not observed. A world free and a pretense that there is a world free of Heisenberg's uncertainty principle. As an academic psychologist for nearly 40 years or 30 years, I would continually challenge my students to think about psychological experiments in terms of the uncertainty principle and how psychological science has been distorted by the incapacity to recognise the uncertainty principles operating in many experimental situations. It also, psychological endeavours and neuroscience fail to distinguish the individual from the person. Many people take the individual as the unit of any sort of inquiry, and but its etymology reveals that it actually is with the Latin root videre for as to see as in evidence and video, and it means literally to be unable to be seen in parts, that is a whole unto itself. Individualism is the belief that an individual acting alone can make choices most best beneficial for self and for those closest. Within individualism, there is nothing between people. I prefer to use the word person, and as Sanders suggested, it can be translated as sounding through. Sonare is the verb for hearing, and pair is usually translated as with, but you can have it as sounding through. That is, we know ourselves through the conversations with others and the feedback they supply. The terms of personhood used in common conversation, me, myself, and I, separate the subject me from the agent I and the continuity of the experience of others that is felt to be the object, that is the self. When we have these all folded into each other, like Freud translated did, we end up with the idea of the ego, id, ego, and superego. When they retranslated Freud in the 2000s and 2010s, Adam Phillips and Mark Solms, they found that Freud was actually using me, myself, and I quite frequently. But Strachey found this to be rather confusing, and so he invented this term ego. And ego has become to mean something solid and definite, whereas it was never meant to be in the original ideas of Freud. Freud, of course, was an individualist, and not many people know that he was the translator of John Stuart Mill into German. Freud was fluent in German, French, quite good in Italian, quite good in Spanish. Freud claimed that but here we need to say that he claimed that the unconscious was a third decentering of humanity following the observation of his mentor, Émile de Bois-Reymond, in an 1882 obituary for the death of Charles Darwin, who described, de Bois-Reymond described the first decentering as that of Copernicus and the second as biology. evolutionary theory is decentering biology. Freud thought that his unconscious was a decentering of the person, but in fact, the third decentering occurred long before the other two and created the circumstances for communities of inquiry to form and ask significant questions about the universe. The first decentering occurred with the emergence of language within the species. Gone too quick. John Bowlby would be known for his work on attachment theory. He was a psychoanalyst, and he was concerned about the way children could not reattach to their families following separation during the times of the Battle of Britain in the Second World War. He considered his greatest work was his final one, which is a huge book, a hagiography of Charles Darwin. And the focus in the book is on the individual person is total. Yet it was the language capacities of the species that enabled the production of On the Origin of Species. Attachment theory has enabled the important work of Ainsworth, Main, Crittenden, Tronick, Stern, Trevarthen, Siegel, Shaw, Fonagy, Holmes, and Hughes. Lots of people think take attachment as a given. And in cognitive behavior, third wave cognitive behavioral theory, you have with schema therapy takes attachment theory as its developmental theory. But attachment theory is a theory of love, but not a theory of hate. Hate is the effect of the absence or withdrawal of love, which is for most people counterintuitive. The phenomenon described by attachment theory can be described without the use of the attachment terms. Babies need to be close to their mothers. They come from physical closeness and need to adapt to the loss of this closeness, as do mothers. Trevarthen's notion of adventures in companionship makes sense at a species level. Similarly, Panksepp's theory of the 7 primary emotions is a theory applied to all mammals. We need to theorize psychologically at the level at which at the level of the species more often than the level of the individual. If we focus on the individual, we end up with chaos about which particular ideas are actually valid. Dan Siegel has been very strong in attachment theory and in parenting and so forth, and it's really emphasized the need to understand what happens between mother and child at the neurobiological level, and has started his own institute, and in 2023 produced a paper on interpersonal neurobiology. It looks like he's trying to talk about how to something interpersonal, but in the end, he comes back to what's called the wheel of awareness and things that happen inside the person, not between people. And his use of language terms, although he says we should be clear about them, he is linguistic rather than he is meaningful in his use of these words. I could go over that, but I don't need to spend time too much. They recycle and restyle certain words with acronyms, COAL, PART, and SPAR. It's a very clever piece of individualizing what was supposed to be something that was interpersonal. Susan Greenfield is an English romantic, in my view. I attended a seminar of hers, and I wondered about 8 problems that her presentation was going to be a focus on the individual rather than the species. It was going to be about the separateness of the individual from language, belief in consciousness without language, belief in evolution occurring outside of language, and that avoidance of the of accounting for the Heisenberg uncertainty principle in her consciousness research, no consideration of Panksepp's basic emotions of mammals, and avoidance of how all is rendered in language, and that a confusion about the neurobiological processes, neural and biochemical, but that these were mediatory rather than causal. There were lots of things that are really interesting. Her presentation on the difference between the human mind and computer processing was apt. The simple conclusion: we should let computers and machines do what they do best, and that we do what we do best. Brains and silicon are different stuff. Neural networks are complex systems of biochemical weaving, not direct circuitry. Greenfield thinks she studies individuals. I think she studies neural processes that occur within mammalian bodies. Ultimately, she is a romantic individualist. Then we go to the case of Paula, and what I really wanted to get through here was that this little girl had 6 years of treatment from an ankle injury, a shoulder injury. She started to lose her eyesight. She lost her grandparents. And then she was cured in 3 weeks by a hospital admission and having a diet-adjusted sleep medication, a little bit of anxiety, lots of what was called body talk, and school time to return to usual follow-up. Kotlowska tries to explain all this through brain-body series and whatever, but I think it's better and it's simpler to say that she had a belief in her physical injuries, and only a hospital could cure her physical injuries, and a 3-week in 3-week period in hospital cured what had been impossible to cure in 6 years. We get mixed up with our explanations and which may be mediations rather than causes. Neuroscience is a way of speaking that cannot exist outside of language, even if the phenomena described would prevent language in a damaged individual. We live in language. Through our lives, we reproduce language. This has been happening for millennia. We are at the mercy of gravity and evolution, but language enables adaptation. We need to speak with each other and find solutions to climate change and war, or we will be truly decentered. And this is the words Penelope Lively described in her novel Moon Tiger. We open our mouths and outflow words whose ancestries we do not even know. We are walking lexicons. In a single sentence of idle chatter, we preserve Latin, Anglo-Saxon, Norse. We carry a museum inside our heads. Each day we commemorate peoples of whom we have never heard. More than that, we speak volumes. Our language is the language of everything we have read. Shakespeare in the authorized version surface in supermarkets, on buses, chatter on radio and television. I find this miraculous. I never cease to wonder it, that words are more durable than anything, that they blow with the wind, hibernate and reawaken, shelter parasitic in the most unlikely hosts, survive and survive and survive. Thank you for allowing me to speak.
Stage 2, Psychiatry Registrar at the Royal Australian and New Zealand College of Psychiatry, and I'm currently working at the Royal Melbourne Mental Health Service. I've just put my email there below if anyone has any questions, as I won't be able to get through all the information on my slides, but more than happy to have a discussion over email. And today I'll be talking about the rise of nitrous oxide use, discussing a case study. And what I'd like you to take away from this presentation is mainly to understand the increasing prevalence and risks associated with nitrous oxide use. So in terms of statistics, research shows that compared with people with a single disorder, i.e. a mental illness or substance use disorder, people with dual diagnosis have higher rates of severe illness cause and relapse. They have increased risks of violence, suicidal behaviour, increased use of service use, and also social difficulties such as experiencing poor outcomes. The age stage and of their development makes them more vulnerable. And emerging adulthood is the age period when prevalence is highest for most types of drug use. In 2019, a survey completed in Australia found that 24% of young people aged 14 to 24 had engaged in illicit drug use 12 months before the survey, with highest amongst 18 to 20-year-olds and 21 to 25-year-olds close behind. The most common factors cited for the reason for youth was to see what it was like, friends or family were using or being offered by a friend or a family member, and the third one was to do something exciting. Nitrous oxide bulbs are cheap and readily available, particularly in Australia, and it's often called NANGs here, which I'll use to refer to it for the rest of the presentation. Nitrous oxide is classified as dissociative anesthetic and is typically inhaled by discharging the nitrous gas cartridges, bulbs or whippets into another object such as a balloon or directly into the mouth. And inhaling nitrous oxide produces a rapid rush of euphoria and feeling of floating or excitement for a short period of time. While there's no isolated data collected on nitrous oxide use in Australia, recent use of inhalants, including nitrous oxide, has been gradually increasing. And the 2021 Global Drug Survey listed nitrous oxide as the 13th most popular recreational drug in the world. So quickly moving on to the case presentation. So I'll be presenting a 24-year-old male of Somalian background who self-presented to the emergency department with his cousin in the context of a 3-month decline in his mental state, which was characterized by behavior changes, verbally lashing out at his family. He'd recently been fired for work after shouting expletives to his CEO and voicing some paranoid thoughts. He also had paranoia about his family and neighbours, increasing depression and anxiety, suicidal thoughts with a plan to jump in front of a train, hearing voices, racing thoughts, and had been sending multiple nonsensical texts to his father. In terms of his past psychiatric history, he has a diagnosis of autism spectrum disorder and ADHD, which were both diagnosed in March 2022 by a private psychiatrist who had prescribed him some Vyvanse. In terms of his medical history, so he had right lung sequestration, he had a mild head injury in 2011 with no intervention required and an adenoid removal. His medications were Zylizdex, amphetamine 50 milligrams orally in the morning, but he had been non-adherent for just over a year due to his scripts being stolen. In terms of his substance use history, so he started cannabis use at the age of 18 at university, and this coincided with meeting new friends who were also using drugs. He was initially using 1 to 2 grams of marijuana per week, with occasions of no use. In the last year, this had increased to 2 to 3 grams. This had now begun to impact his studies, and he was, for example, he would smoke in the university car park instead of attending his exams. And he reported experiencing paranoia when he was smoking daily. In terms of his nitrous oxide use, this had started in September 2023, where he attended a party where his friends had bought a significant amount of NANGs, and the next day he went out and bought his own NANGs to use. He was initially buying large canisters and then switched to the smaller bulbs as he found these more tolerable. He'd been using up to 400 to 500 NANGs per day in the last few months and had spent approximately $15,000 on NANGs within 3 months. He'd last used the day of admission, and in terms of effects, he'd experienced a recent symptomal episode where he'd passed out for 10 to 15 seconds after use. He'd experienced visual hallucinations whilst using and had been experiencing intermittent neurological symptoms, including back pain, paresthesia, and gait disturbance. In regard to his family history, he had a prominent family history of schizophrenia, so an older brother who had a diagnosis as well as multiple uncles, and one of these uncles with the schizophrenia diagnosis had died by suicide in 2019 by jumping in front of a train. So in regards to his personal history, he lives at home with his family in a sibship of 4, and he is currently single, never married or fathered any children. His mother and father are still married, and his eldest brother works as a doctor overseas. He denied any childhood trauma or abuse. He's of Muslim faith and was recently supposed to board a flight to Saudi Arabia for the purpose of Umrah, which is a non-obligatory pilgrimage in Mecca for Muslims, as he believed this would help fix him and cut off his access to nitrous oxide. He described his relationship with his family, particularly his father, as strained in the context of substance use. He described his father as having a sharp tongue and explained that they would go for periods of 2 to 3 weeks without speaking to each other. He noted that when he told his father that he was in hospital and he was embarrassed. His father replied, "Me too." He reported previously being very outgoing but had stopped socializing with friends, opting to use drug instead, and was now feeling generally unsupported by his family. In terms of education and employment, so he had attended both public and private schools in Australia and had done very well in his school. He stated he did well without trying and was able to achieve well with minimal effort. He did well in his first year at university, and then his academic performance decreased, scraping through in subsequent years. And it took him 6 years to complete his Bachelor of Science, partly because he also took 1.5 years off due to work and travelling. After university, he began working at Afterpay in software development and reported finding the work easy. He was previously working full-time, but had cut down to 3 to 4 hours per week in the context of substance use, and as discussed before, his employment had recently been terminated. So in regards to his admission MSc, I'll let you have a read, but the main things were that he presented as sad and perplexed. He admitted to suicidal thoughts. He was experiencing paranoia. He had no recent hallucinations, with the last experience around a month ago. And he had some insight into his addiction to NANGs. He recognised he needed treatment for his psychiatric symptoms. In regards to his medical examination, so his cranial nerves are mostly intact, except he had decreased sensation in cranial nerve 5. His upper and lower limbs, so he had altered sensation and paresthesias from his midfoot down to the soles, particularly affecting his left big toe, which the neurology registrar queried was in a length-dependent manner. His gait was normal, but he reported subjectively feeling unsteady. He was able to walk heel-toe with encouragement, and he was Romberg negative. And here were his investigations. So his CT was normal, and he had vitamin B12 deficiency. So in terms of formulation, presenting a 24-year-old male of Somalian heritage who presented to the emergency department with suicidal ideation in the context of deterioration in mental state, characterized by the emergence of psychotic symptoms, also experiencing neurological sequelae of nitrous oxide use, including paresthesia, mild ataxia, and worsening cognition. He has had a recent diagnosis of developmental disorder, and additionally he has a notable strong genetic predisposition for psychosis, with a number of family members with a schizophrenia diagnosis. Due to his age, he is at increased risk of harmful use and addiction. His difficulties can be understood as arising from his core negative self-worth. He described a family where he perceived his mum as nagging and his dad as particularly punitive and hurtful, with feelings of lack of respect displayed towards him by his father. Additionally, he'd experienced pressure to achieve highly like others in his family. Therefore, ultimately, he saw the family home as more damaging than helpful, and wanting to find an escape from this environment, he found it in substances. He displays low distress tolerance when his needs are not met, and substances provided an immediate ameliation to his distress. And due to his developmental disorder, particularly his ASD, he was quite rigid. He reports experiencing anxiety and trauma when he was robbed and intimidated with a gun, which led to his scripting for his lisdexamfetamine being stolen, and his cannabis use increased after ceasing the Vyvanse. The introduction to nitrous oxide with his friends provided him with more instantaneous relief, and his use snowballed from there. His nitrous oxide use seemed to give him experiences that he then incorporated into his delusional content. As his psychotic symptoms increased, his use increased as a form of self-medication. Additionally, as his substance use increased, his friends of choice gravitated towards those who used substances. After losing his job due to decline in his work performance and his psychotic symptoms, he experienced an increased sense of letting people down, including his friends who helped him find a job, but also his family, particularly in the context of being in a family where work achievement is regarded highly. Ongoing perpetuating factors that impact his prognosis is his inability to tolerate his own effect. He displayed a very low threshold to medicate his thoughts and used pharmaceuticals whenever discomfort arose. He was reluctant to learn new adaptive coping skills. He has now experienced a loss of both his work and also his health due to substance use, and He buries his worry and uncertainty about future outcomes. He is withdrawn from both family and friends, which leaves him open to fill his time with more substance use and also limit his supports. So in terms of the impression, it was first episode psychosis in the setting of recreational drug use, with a differential diagnosis of schizophrenia, polysubstance use with nitrous oxide and cannabis, and vitamin B12 deficiency with paresthesia resolved. So just quickly in terms of his management timeline. So he was reviewed by neurology, who felt there was no clear evidence of subacute combined degeneration based on the physical exam. And there was absence of anemia and macrocytosis, but he was vitamin B12 replete. They followed the management for chronic nitrous oxide toxicity, which is vitamin B12, 1 milligram daily IM for 2 weeks, weekly for 4 weeks, and monthly until maximal recovery, and they administered methionine. There was no need for nerve conduction studies or MRI studying at this point. He was transferred to AMU for ongoing medical consultation, and his distal paresthesia improved. He had consultant liaison input, and he agreed to a voluntary admission in the psychiatric ward to support his recovery. He was nursed in the low dependency unit of the psychiatric ward, and he presented as more settled and did not endorse any ongoing psychotic phenomena, but he did display anxious ruminating. He regularly sought diazepam and presented as irritable when his needs were not quickly met. He was granted escorted leave with family and eventually unescorted leave. A few days prior to discharge, he did have some momentary misinterpretations and delusional perceptions, but he was able to correct these quickly. In terms of medications he was commenced on, so he was commenced on initially 10 milligrams olanzapine nocte, but this was increased to 5 milligrams in the morning and 10 at night in the context of frequent olanzapine PRN use for his rumination and agitation. He had gained significant weight and increased appetite on the olanzapine in the 2 weeks he was on the ward, and so he was cross-titrated to lorazepam for a better metabolic profile. He was seen as a psychologist on the ward who focused on values, life direction and self-worth, which were closely linked to his job. Social work provided a support letter to explain the circumstances of deterioration of mental state and advocating for his job back, and he engaged with exercise physiology for meaningful physical activity. So he was discharged on lorazepam 80 milligrams nocte, his hydroxycobalamin injection, and methionine peroxidine. And as well as olanzapine at 5 milligrams as required at night for sleep. He was referred to the CAT team, which is our crisis acute team, to monitor mental state and risk and monitor response to his increased lorazepam dose. And he was going on a 6-week trip with his family, and they were to support to make sure he had enough medications for that trip. He was also referred for case management for first episode psychosis follow-up. Unfortunately, he represented after 6 weeks. He had actually left for the family holiday the day after discharge and had not had any medications since he left hospital. He had worsening intrusive thoughts and was requesting diazepam in the emergency department. He was actually just provided with his scripts for his medications and referred back to the crisis team and the case management team. But 10 days later, he represented again and had taken an average of 400 to 600 nangs per day over the last 4 days, with 600 the day prior to presentation. He had become paranoid, hallucinating both visually and auditories, and he developed numbness, tingling in hands and feet and periorally. So he decided to present to a hospital. Due to the paresthesias, unfortunately he had fallen whilst walking and sustained a deep laceration to his knee, which required sutures. I say this just to kind of highlight the risk of substance use and the risk of dependence in young adults. So quickly, just discussing nitrous oxide in the last 5 minutes in terms of the mechanism of action. So just this goes through. So the anesthetic effect of nitrous oxide is through non-competitive NMDA inhibition in the central nervous system, and analgesic effects occur by releasing endogenous opioids that act on opioid receptors. Anxiolytic effects are through GABA A activation, and it has central sympathetic stimulating activity and stimulates cerebral blood flow and increases intracranial pressure. In terms of the mechanism action between nitrous oxide and vitamin B12, Nitrous oxide causes oxidation of the cobalt ion in vitamin B12, thereby rendering it inactive, and this leads to functional vitamin B12 deficiency even with normal stores. Without vitamin B12, homocysteine cannot be converted to methionine, which prevents methylation of myelin protein and leads to demyelination in the peripheral and central nervous systems. In the spinal cord, there is a predilection for demyelation in the dorsal columns, leading to myelopathy due to subacute combined degeneration of the spinal cord. In the peripheral nervous system, ischemia has been suggested as another cause of neurotoxicity, but unrelated to the direct effect of vitamin B12. It's critical to check the homocysteine and MMA levels, which are functional indicators of vitamin B12 status and are elevated in greater than 98% of patients with clinical deficiency. And elevated MMA is the specific for vitamin B12 deficiency, whereas homocysteine may also be elevated in patients with folate deficiency, renal failure, and hypothyroidism. In terms of the neurological symptoms, so patients can present with varying degrees of upper and lower motor neuron involvement. Spinal cord involvement manifests as spasticity, pyramidal pattern weakness, and dorsal column sensory loss, whereas peripheral nerve involvement results in length-dependent large and small fibrous sensory loss, and visual disturbances can occur. In terms of why psychotic symptoms occur with nitrous oxide use, in literature we're not entirely sure. It's been postulated from the vitamin B12 deficiency, but also it's been hypothesized that the psychomimetic effects of nitrous oxide, such as hallucination, agitation, and disorientation, may be due to the non-competitive antagonistic action at the NMDA receptor. In terms of treatment of the neurotoxicity, so you cease nitrous oxide use and immediate administration of hydroxychloroquine. Folate deficiency should be corrected alongside vitamin B12, and patients with severe symptoms may benefit from a period of neurorehabilitation. And neuropathic pain should be treated along standard guidelines for neuropathic pain. I'd quickly just like to refer to a systematic review, which you can take a look at in more detail by Ratchathani et al. And this was a systematic literature review of 91 cases of nitrous oxide use, and they separated the presentation into neurological, psychiatric, and medical. And neurological complaints were the most, so 72 cases. Primary psychiatric complaints were in 11 cases, with the most common symptom at presentation being delusion, and then there was some non-neurological medical complaints. And I'd quickly like to highlight nitrous oxide abuse and death. So there were 11 publications on nitrous oxide abuse and death, and it included a total of 29 cases reporting to nitrous oxide related deaths. So we just really want to highlight in terms of the risk associated with the ongoing use. So the takeaway points are young adults are at risk of more harmful substance use and dependence, and nitrous oxide is becoming increasingly popular among young adult populations. In young people, using frequent nitrous oxide use ensure investigations of B12, homocysteine, and MMA are completed, and provide psychoeducation to young people regarding the neuropsychiatric risks of nitrous oxide, as well as the risks of death. These are just the references. I'm more than happy to answer questions via email. Thank you, everyone.
My name is Ariadna, and I am a neurologist-based hospital in Sydney, Australia. And today I will talk to you about a project in which I've been working on for more than 5 years now, and it is the topic of my PhD. These are our disclosures. And here you can see the outline of my presentation. The study is still in development. We're currently conducting the analysis of its first stage, and today we'll discuss some preliminary results and outline future directions. Multiple sclerosis, or MS, is an immune-mediated inflammatory demyelinating disorder of the central nervous system. It is the most common non-traumatic disabling neurological condition among young adults, and it normally presents between the age of 20 and 40 years old. Although the exact etiology it is unclear, this is a multifactorial disorder in which genetic predisposition, pathogen infections, especially Epstein-Barr virus, and other environmental influences such as smoking and low vitamin D levels play a crucial role in the development of this disease. From a pathological perspective, MS is characterized by the immune system attacking the myelin sheath that insulates nerve fibers in the central nervous system. This process involves activation of T lymphocytes and B cells, which infiltrates the CNS and trigger inflammation, leading to demyelination and the formation of plaques. Over time, chronic inflammation can cause neurodegeneration and axonal damage, contributing to permanent disability. As myelin is damaged, nerve conduction becomes disrupted, resulting in a range of neurological symptoms. The disease typically presents with episodes of relapse and remission, reflecting fluctuating nature of the inflammatory process, and the range of the symptoms is very wide, as you can see in this image. In a small proportion of patients, around 20%, the disease will have a more progressive course, during which the patients don't improve from previous relapses, and this is called secondary progressive MS and primary progressive MS. Damage to the myelin results also in the characteristic MS plaques or lesions, which can be observed on magnetic resonance imaging or MRI with an ovoid morphology, abutting the corpus callosum, but also involving other areas of the brain, such as the cortex or posterior fossa, and also the spinal cord. While normally the size of the MS lesions varies or ranges from 3 millimeters and 1 to 2 centimeters, in some instances this lesion can be large, sometimes occupying most of the cerebral hemisphere, and this form of MS is called tumefactive MS. Tumefactive MS or tumefactive demyelinating lesions, or TDL, encompass a rare variant of the disorder. They are defined as lesions larger than 2 centimeters in diameter. They do have other characteristic radiological features, such as ring enhancement or large edema, but without mass effect. And due to the size of the lesions, it is common to see these patients presenting with severe symptoms such as hemiparesis, hemisensory deficits, aphasia, apraxia, and even seizures. Up to date, there's no cure in general for MS, despite a large therapeutic armamentarium with more than 17 different drugs approved in many countries around the world, including Australia. This complex landscape becomes even more challenging for patients with tumefactive MS, for which it is unclear which therapeutic strategy are most effective. So apart from the clinical presentation and the changes observed on MRI, which other tools are available for the management of these patients, and more specifically to help with prognostication, treatment choice, and monitoring? The hallmark of MS diagnosis are the so-called oligoclonal bands, which are identified in CSF through a lumbar puncture, and they are reflecting an immune-mediated disorder within the central nervous system. Through electrophoresis, they can be observed, as is shown on the right-hand side, as multiple bands within the CSF without bands in the serum. The last biomarker I would like to share with you today is called neurofilament light change, and this I will focus the rest of the presentation on this one. Neurofilament are neurospecific cytoskeletal proteins which are constantly released from axons, reflecting aging. However, during axonal damage, neurofilaments are released in larger quantities into the extracellular space or CSF and eventually into the blood, where they can be measured using a highly sensitive technology called SIMOA, or single molecule array, developed by Quanterix. Neurofilament light chain is currently the most widely studied biomarker among all neurological disorders. They are significantly elevated in the CSF and blood of patients with MS, but also traumatic brain injury, dementia, or ALS, among others. In MS, elevated serum neurofilament levels correlate with disease severity, disease activity, progression, brain and spinal cord atrophy, and response to treatment. It should be mentioned that neurofilament levels can be influenced by other factors other than aging, such as BMI, kidney function, and diabetes. To address this, a team in Switzerland, led by Professor Kuhl, has developed a reference database through the measurement of serum neurofilament in around 5,000 healthy controls. The results were adjusted by age and BMI, which they found were the two most significant independent variables. This database allows individual results to be interpreted using adjusted percentiles and z-scores as shown on the graph on the left. From this graph, it can be interpreted also that the normal values for individuals up to 50 years old are up to 10 picograms per milliliter, and after in subjects older than 50 years old, these levels continue to gradually increase. The application of serum neurofilament in tumefactive MS has been minimally explored so far. There's only one study with a small cohort, so we are hoping that our data and results will add value to the current literature. With our study, we aim to investigate severity of tumefactive MS through markers of neurodegeneration, such as brain and spinal cord atrophy using IcoBrain MS software, and serum neurofilament light chain measurement using SIMOA technology. For this, adult patients attending an MS clinic in a tertiary hospital in Sydney were invited to enroll in the study. All participants were required to have a baseline neurological assessment, brain MRI, and a blood sample for assessment or measurement of serum neurofilament. I will focus my presentation, the next section of results, on this biomarker. Patients were then classified into conventional MS or tumefactive MS. (364 participants were included in total. All subjects had a baseline MRI, and above half of the cohort have also retrospective imaging, which will allow a retrospective and prospective analysis. And 83% of the cohort had a baseline blood sample for neurofilament levels. 269 patients were classified as conventional MS, and 82 had a diagnosis of tumefactive MS. In terms of other demographics, 2/3 of the cohort were female, with a female-male ratio of 2.47, which is in line with what is described in the literature. The mean age at blood sample collection was 48, and the mean disease duration was 13.6 years. When accounting by our clinical presentation, around 80% of patients had a relapsing remitting form, and just above 20% had a progressive form of the disease. A comparison of the raw values of serum neurofilament levels without including age and BMI, because this data is incomplete at this stage. In both groups, analysis was performed, and the results are illustrated in this combined dot plot and box plot graph. As you can see, there are notable differences in the central tendency and the presence of outliers, with lower median values and less outliers in the conventional MS compared with the tumefactive MS. And although these results should be interpreted with caution, they might be indicating a greater level of axonal injury and neurodegeneration among patients with tumefactive MS compared with conventional MS. And although I have not shown it here, we did also run an analysis including age, and there wasn't any significant changes there. But we haven't included BMI yet. When comparing by groups of MS type, the relapsing-remitting group shows lower median than the progressive MS patients, suggesting that serum neurofilament levels tend to be more elevated among patients with progressive disease. Again, this might be implying greater degree of neurodegeneration on this cohort, which is in line with what is described in the literature. However, patients with progressive MS are also older, as you can see in this graph, which may partially explain some differences in mean concentrations levels observed between the two groups. Seems there's been an issue with that downloading the content of that slide, which I'm happy to go through. I'm not sure about the organizers having for me to go through it. So I apologize about that. I'm not sure what happened with the end of that presentation.
All right, thank you so much. That was an excellent presentation. If anyone has any questions or directly like to ask the doctor, just turn on your mics or you could drop it in the chat box.
Sorry, I couldn't see the last two slides. Could everyone else see the future directions and conclusions of my presentation?
Sorry, could you repeat? You couldn't see the last two slides?
Yeah, I'll put my headphones on.
Hear me better now? Is that better?
Yeah.
Yeah, I couldn't see the last two slides of my presentation. Just wanted to make sure that they came through.
Okay.
Oh yeah, maybe it was just me. Yeah. So yeah, happy to take any questions or the viewers.
Specialty of Preventive Medicine, Community Mental Health. Today, I will present you my research, prevalence and factor affected state and depression of the parents who have children aged 5 to 11 years in post-COVID-19 pandemic situation in Muang District, Ubon Ratchathani, in Thailand. The World Health Organization has declared COVID-19 to be a new emerging disease that has a large epidemic. Most patients will have respiratory symptoms, and if infection occurs in high-risk group, it will increase the severity of disease, pneumonia, and even death may occur. In Thailand, same the other country, we have widespread of COVID-19, and have accumulative death rate of 437 cases per million population. The widespread outbreak of COVID-19 have caused adverse effects on physical and mental health, especially state and depression among patients, medical personnel, general public, include state within the family, especially in family with small children, because of household economic problem, and young children have developed mental problem due to lack of activity outside the home that promote development. In PubMed, I cannot find the research that I cannot find the research about state or depression of the parent in post-pandemic situation of COVID-19. This study therefore aims to study the prevalence and factor affecting state and depression among parents with children aged 5 to 11 years in Ubon Ratchathani province in post-COVID-19 pandemic situation, in order to provide guidelines in planning the prevention of state and depression in the target population in the future. This research is cross-sectional analytic study conducting in July 2022 by conducting an online survey via Google Form. The sample group was the parent of children aged 5 to 11 years study in kindergarten to grade 5 school in Muang District, Ubon Ratchathani province in Thailand. Inclusion criteria that the parent who is 18 years old or older and can read, write, and understand Thai, not a psychiatric disease such as depression. Data were collected from 1,100 people randomized select from 6 schools out of 37 schools using statistical random sampling. The research tool is a questionnaire developed by the researcher divided into 7 parts consisting of Part 1, general information. Part 2, information about family members' experience with COVID-19 and receiving the COVID-19 vaccine. Part 3, concern about family members being infected with COVID-19 and confident in the educational institution preventive measure. Part 4, recognizing information about vaccination and COVID-19 prevention from various sources. Part 5, information on COVID-19 prevention behavior. Part 6, state assessment form or ST5 by the Department of Mental Health, Administration of Public Health, and Part 7, depression screening form to patient or 2Q, and depression assessment form 9 questions of the Department of Mental Health. 4 research questions: the prevalence of state and depression among parents, the level of concern of parents regarding COVID-19 infection of their children, the behavior to prevent the spread of COVID-19 from parents to children, and the factor affecting state and depression among parents. I analyze the data by technique, analyze the prevalence of state and depression, and list factor for such condition with descriptive statistics using percentage, mean, and standard deviation. Factor affecting state and depression were analyzed using multivariate logistic analysis. Result and conclusion. There were a total of 1,100 people answering questions in the online questionnaire. Majority were female and have a bachelor degree. Income is on average. Nuclear family and average of children aged 5 to 11 years in the family 1.5 people. Majority of the sample received at least 2 shots of vaccine, and their children aged 5 to 11 years in their care received at least 1 shot either. In addition, most were moderately worried, concerned that their child would have COVID-19 were moderate. The channel of receive information and advice on prevention of COVID-19 and vaccination of young children more in social media, such as YouTube, Facebook, and television. And the channel for receiving information from the school more on school website and communication online, such as Facebook. The sample group most moderately confident on COVID-19 prevention measures in school. Behavior to preventing COVID-19. Most common preparing and wearing face masks for children every time when leaving the house or going to the community. And almost percent of the sample, about 89% of the sample group have behavior to prevent COVID-19 infection and take appropriate care of their children. State and the patient state I cut point at suspected of having a state problem and high state. I found the prevalence of state about 32%. And depression I cut off at mild depression and moderate depression and severe depression. Prevalence of depression about 21%. When I analyze by multivariate data analysis, the factor affected state include children 5 to 11 years old in family having COVID-19, worrying that there will be have COVID-19, low confidence in school measure, and having behavior to prevent infection at a level that should be improved. And factor-related depression, when analyzed with multivariate data analysis, I found that factor affecting depression include not have a job, worrying about being infected with COVID-19, not receive public information about COVID-19 vaccination from the hospital, and having behavior to prevent infected at a level that should be improved. But the factor affecting both parent state and the patient in this study were concerned about being infected with COVID-19 and having behavior to prevent infection at a level that should be improved. Research application. In this research, factor affecting both parent state and the patient in this study were concerned about being infected with COVID-19 and having behavior to prevent infection at a level that should be improved. This is consistent with the study by Kitkanton et al., which found that poor level of self-protective behavior from COVID-19 were related to state. Therefore, there should be measures to encourage the sample to have behavior to prevent infection at an appropriate level. Study by Dongdao and colleagues found that health literacy was positively related to self-protection behavior from COVID-19 among published health volunteers. Therefore, I host educational institution, which are channels that can easily reach parents should cooperate with local health facility in organized activity to enhance health literacy in preventing infectious disease for parents and study periodically. There are publicized channels for receive vaccine, measure to screen for state and depression among parents and study, and channel for people with high level of state and depression to access counseling service such as basic psychological care and assistance over the phone. There is regular communication with the parent group about measure of control the spread of the epidemic within the educational institution to reduce anxiety and may consider include teaching content of appropriate behavior to prevent infectious disease into health education subject for students. This is a limitation. Data was collected using online questionnaire, making it impossible to assess the risk of suicide among samples with 9 question score of 13 or more. The inclusion criteria was being a parent who does not have a psychiatric disorder. This may lead to an under-reality prevalence of state and depression, and the question about COVID-19 prevention behavior lack assessment of validity and realizability and divide into behavioral level by the researcher. Okay, thank you for attention. Any question?
To present my presentation. Before I start, let me introduce myself. I'm a neurologist from Department Neurology at the Faculty Medicine Universitas Sumatera Utara, and I'm currently pursuing a doctoral program at the Universitas Sumatera Utara. Okay, now I will start my presentation with the title Trifolium pratense leaves extract enhances cerebral neurogenesis in rotenone-induced and in Parkinson disease. For introduction, Parkinson disease is a progressive neurodegenerative disease distinguished by both motor and non-motor symptoms. For the motor symptoms, such as slowness of movement or bradykinesia, we can see in Parkinson disease patient, muscular stiffness or rigidity, tremor, actually at the rest, poor postural stability, soft voice, shuffling gait, freezing, and akinesia. And from the non-motor symptoms, we can see such as constipation and insomnia. Parkinson disease is a neurodegenerative disorder that constitutes a real major public health problem, which is considered as the second most neurodegenerative disorder in the world after Alzheimer's disease. Essentially, define severe depletion 80% until 90% of dopamine in the striatum, following a progressive and irreversible degeneration of the dopaminergic neurons, and until now, no drug has yet been found that can inhibit the progression of Parkinson disease. The pathophysiology that is happening in Parkinson disease, such as aggregation of alpha-synuclein, mitochondria dysfunction, lysosome dysfunction, and neuroinflammation. And for the inflammation process in Parkinson disease, consists of peripheral inflammation and central inflammation. They cause the neurodegeneration in the brain. The relationship between alpha-synuclein and Ki67 has same process in neurodegeneration. And for today, the treatment of Parkinson disease that is given levodopa, agonist dopamine, deprene stimulation, palidotomy, and thalamotomy. Polyphenol or phytoestrogen has neuroprotective effects, and one of them is an isoflavone. Isoflavone can improve neurotrophic factor like BDNF or brain-derived neurotrophic factor, and it makes increasing Ki67. And Trifolium pratense is a part of isoflavone. They're constitute of formoninetine, biokainin A, didzin, genistein, and have effect antioxidant, anti-inflammation, and neuroprotective in the brain. Neurogenesis in Parkinson disease, from the study in Parkinson disease about the adult hippocampal neurogenesis, showing a decrease in neural stem cells in this patient, and this is related to the formation of alpha-synuclein. And from the other study, research on Parkinson disease animal models induced by neurotoxin like rotenone, paraquat, shows a significant reduction in the formation of new neurons. From this figure, we can see when the tyrosine kinase binding by polyphenol result in the autophosphorylation and activation of this receptor. And then receptor phosphorylation forms adapter binding sites that couple to the receptor to the mitogen activated protein kinase, phosphatidyl inositol 3 kinase, and phospholipase C gamma, which ultimately result in the phosphorylation of CIMP, response element binding protein, and then increase survival, proliferation, and differentiation neuron in the brain. This figure is schematic representation rotenone-induced reactive oxygen species production leading to cell death, then which result in Parkinson disease. And for methods, this is an experimental post-test only control group design. Induction model of Parkinson disease from day 1 until day 7. Ratus novergicus pregdowli, each 2.5 until 3 months, and for the weight 200 until 250 grams. And induction with the rotenone 1.75 milligram kilogram body weight intraperitoneally. And for the interventional Trifolium pratense leaves extract from day 8 until day 35. For the group Trifolium pratense leaves extract 5 milligram kilogram body weights 85, apply once daily in the morning 28 day. And then for the group ET10, Trifolium pratense extract leaf 10 milligram kilogram body weight, apply once daily in the morning 28 day. And Trifolium pratense 20 milligram kilogram body weight, ET20, apply once daily in the morning 28 day. And for the analysis, day 36, termination with ketamine and psilocin injection and brain tissue sampling. And from the result, we can see is the figure of the immunohistochemistry, and that in the normal group, the amount Ki67 is higher compared to the negative control group. And after the administration of Trifolium pratense leaves extract, which show significant formation of Ki67, a dosage 20 milligram compared to control negative, and from compared to the ET5 and ET10 group. And from the graphic, we can see also in the first graphic, the graph shows that the number of Ki67 positive cell is higher in the ET20 group compared to the negative control, and then the ET5 group and the ET10 group. And for the other graphic, we can see the person expression of Ki67 is higher in the ET20 group compared to the negative control, and to the compared to the ET5 and ET10 group. Based on the result of this research and previous study showing increased Ki67 and deoxyuridine as a marker of neurogenesis. And the increase in Ki67 is related to the modulation of neurotrophic factors like BDNF, GDNF due to the influence of Trifolium pratense leaf extract, resulting is an increase in CAMP, response element binding protein, and subsequently cell proliferation. So the Ki67 cell marker observed in the immunohistochemistry examination of this study serve as an indicator of neurogenesis happen in the brain. For conclusion, the present study demonstrated that Trifolium pratense leaf extract increased formation of new neuron as a marker of the occurrence of the neurogenesis in vivo by increasing cell proliferation, Ki67, indicating a potential value of Trifolium pratense leaf extract in the therapeutic of Parkinson disease. And this is my references. Thank you for all of your attention. I return it to the moderator. Thank you.
Assalamualaikum. My name is Dr. Sadaf Konan Ansari, and I am an assistant professor of medical education in Niazi Medical and Dental College, Sargodha from Pakistan. Today, my topic of presentation in this platform is my published part of book, Untamed Mental Wellbeing of Children from Shadow Parenting Families. Being an educationist, I have come to know that the shadow parenting is the lifestyle of a children that cause a lot of trouble in their emotional, social, cognitive development. And that causes children that are in the education system and in contact with different age group of their peers and adults, and they have encountered a lot of social problems. So in this background, I have thought to explore the theory behind that shadow parenting. Why there is a shadow parenting in our society? What happened to the families of those shadow parenting children that are dependent to their parents? In this background, I have searched the theory related to that behavior of that parents and their children. As we know that Freud's theory of emotional behavioral development are emotionally and psychologically attached to their parents. In their early childhood, they copy their parents' activities and their walking style. Related to that, we have come across to know that most of the parents in this digital era, they are working, both parents are working, and they are using their mobile phones, laptops, and tablets for their work purpose and for their social purpose, social media platform purpose, in front of their children, even though we are sitting on the table, but we are not connected. We are available to each other, but we are not talking. And we are eating together, but we are not together on the same table. This drastic neglect behavior of parents in the children's life lead them the insecure, anxious, and untrustworthy environment, household environment, and in their thought, in their emotional environment, they break the connections. This could lead them towards the depressed, insecure, anxious, and in the extreme format, a suicidal person. We have to look around the theory and the understanding of this behavior in order to control or minimize the harmful effects. So the objective of this study is to understand the theoretical framework that lies behind the this untamed mental health well-being. This shadow parenting contribute a poor self-esteem and negative self-image in the children. When the parents are constantly emotionally distant, children may internalize this as a reflection of their self-worth. And they may feel unimportant, unloved, and underserving of affection and attention. As a result, what happened? The children may develop a negative self-perception and struggle with feelings of inadequacy, which can manifest in various areas of their lives. And the most important one is the academic performance, social interactions, and overall self-confidence. So in the last content of this presentation, the important mental health problems arises after this exploration of theory and the modern era impact of digital utilization. We came across to know that the shadow parents may develop attachment disorders because they are present, but they are not present. Emotionally, they are not present. Physically, they may be seen in around the house. And this self-destructive behavior of the children that arise after this kind of weak parent-child relationship may cause them to thought about the self-harm or harm to others or use of drugs or inappropriate behavior among children or other society members, or their dissatisfaction and weak attachment towards their friends or near peer. And after is in this weak background of their lifestyle, we can minimize this lifestyle and bad parenting structure by providing awareness programs, by providing supportive therapy programs, and by providing more parenting guidance and education to such families, and by providing more supportive and parenting guidance within the institutions where their children are learning and go to school at the school's time, and we can create healthier and fulfilling life for themselves and for their families. So the study conclude that the attachment theory, social learning theory, family system theory, and trauma theory, and resilience theory, they all have the connections and deep intermeaning relationship with the development of child psychological behavior. Parents should understand their responsibility towards their children. Parents should understand their availability to their children. And I would like to recommend a future theoretical framework that create and provide our parents the meaningful, lifeful connection with their children. More research and more insightful ideology should be available as in guidelines to all the families who have children below the age of 21. Thank you. Any question?
Thank you. That was an excellent presentation. If anyone has any questions, please turn on your
in Moscow, Russia. This is the first psychological institute in the Russia. It is more than 110 years old. Thank you for your interest in my report. You can ask the questions via the email. In my presentation, I want to share with you how animated tests and mobile applications can be used in psychological diagnostics of adolescents. I believe everyone will agree that today it is difficult to imagine our life without the use of information technology. Smartphones have become an important part of our life. And there is another important growing trend: comprehensive penetration of visual culture into all spheres of life, including the use of visual experience in psychological studies of personality. In order to stay up to date and adapt to the changing environment, 5 years ago we developed an animation test for diagnosing personality traits based on the Big Five model of personality. It is important to understand that animated tests are a new format of pictorial tests. The reason why we chose the Big Five model is that today it is one of the consistently reproducible constructs for studying human personality traits. It is confirmed on various cultural samples of adults, adolescents, and children. So, what is the personality animated test? The test is designed to diagnose 5 personality traits: extroversion, agreeableness, conscientiousness, neuroticism, and openness to experience. It includes 15 situations containing pairs of opposite in mini animated images, animated GIF files. There are 3 situations for each trait. The test includes a 4-point Likert scale. The test is designed for children and adolescents aged from 9 to 15 years. At first, let's look at the test development. At the first stage, we came up with paired situations which had opposite meaning for the diagnostics of extroversion, introversion, neuroticism and emotional stability, agreeableness and antagonism, conscientiousness and impulsiveness, and openness to experience, closeness to experience. At the beginning, psychology experts analyzed all the situations to assess their relevance to the supposed personality traits. After that, animation professionals assessed the possibility of a looped cycle for animated GIF files. In the second stage, we worked on a sketch of the main character and drew storyboards for each situation and movement in the frame. We considered several versions of the main character. In the end, we settled on what, from our opinion, was the best option. After the designer drew the animated images, we gathered a focus group of teenagers. We wanted to find out whether the teenagers understood what was happening on the screen. Initially, we made 96 animated files, but during each stage, described earlier, the situation scenarios were adjusted. Based on the results of these stages, 37 situations were included, 74 animated images were included in the initial version of the test. I would like to draw your attention to the fact that we drew all the GIFs in 2019. And finally, the fourth stage. At this stage, we conducted several studies without using the mobile app yet. In these studies, we checked the factor structure of the test, its reliability and validity. We used available survey sources, As a result of this study, we selected 15 situations from 37. These 15 situations were included in so-called personality animated test. We called the test KeyPad. This stands for the first two letters of my and my colleague's last name and an abbreviation for personality animated test. We have published several articles in Russian on these studies. Let's move directly to the main topic of my report, so the KeyPad mobile application. My main task was to understand whether it is possible to use mobile applications in scientific psychodiagnostic research. The mobile application KeyPad is a test for diagnosing the traits of extroversion, agreeableness, conscientiousness, neuroticism, and openness to experience in the form of 15 pairs of opposite animated images. The application contains brief instructions, collects data on gender and age, and also shows the user the individual results by displaying the points scored on the screen and their interpretation. The text description of the results is presented as a vertical slider with the ability to scroll the text that appears. The mobile application is created using the Java in the Android Studio development environment. The application was tested in the Knox emulator on various virtual models. The application takes up 175 megabytes on the smartphone. All the test results are saved in the database and, if necessary, converted to Excel format. The application is not in the public domain because we pursued research and demonstration tasks. In order to use the application, we created an APK file. Using this file, you can install the application on your mobile device. Using a mobile application, we conducted an empirical study on a sample of teenagers. As you can see, according to the Cronbach's alpha and McDonald's omega coefficients, all scales have good internal consistency. Based on the results of exploratory and confirmatory analysis, we confirmed the 5-factor structure of the test. To check the validity, we used the Big Five questionnaire, children version, developed by Barbaranelli, Caprara, Rabasca, and Pastorelli. The correlation coefficients are presented on the slide. In conclusion, I would like to note that in recent years, the number of applications with personality tests on the Android and iOS platforms has increased significantly. A wide selection of such applications is presented on special resources. However, as a rule, they are aimed at an adult audience and offer the user well-known survey tests in form of questions displayed on the screen. For example, the Myers-Briggs test, value orientation questionnaire, etc. If necessary, you can find reviews with the best applications in this segment. Their main difference in the interface and the set of tests offered. And to this day, I have not come across scientific articles that would talk about animated personality tests. Of course, I do not exclude they already exist. Thank you for your attention.
I would like to now welcome Dr. Barak.
In my first works, Metaphysica and Perception, in Italian Metaphysica and Percezione, I argue against the thesis of naive realism. I argue that what we see, what we experience better, is not the world in itself, but we live in our experience. I underline that there are three kinds of subjects. We inner the experience, that we are the conscious, our conscious representation inner experience, the representation of us perceptually inner the experience, and the body that is inner the environment and in itself. The conscious subject, the perceptual subject, moves in the environment itself through the body. And the first and the second and the third are linked to live the environment in itself. But what we experience is not the environment in itself. This implies that the others are not the others in itself, but they are like phantasmas in our experience, and they enter in our experience, and better is the experience with them, better is our knowledge of the others. We are in experience phantasmas between phantasmas. In Color's Brain and Immateriality, with Paolo Bartolomeo Pascolo professor, we search the link between visual field perception and the brain. And we expose a way for what we can, from the brain, we can have linked to the neural work the world of experience, and in particular the visual field. A neuron is linked more or less with a representation of an immaterial part of the neuroelectric phenomena which compose the entire visual field. My research go ahead with the mind-body problem. In an article appeared on Journal of Neurophilosophy called Where and What? Two Experiments for Dualism, I argue that the where and the what of experience are not the where and the what of the body. In neuroscientific research about out-of-the-body experiences, we have subjects that see themselves in a place and in a way that is not the place and the way that they are bodily, really, in the experimental set. The subject, while they are sit on the experimental set with visors, they see themselves from the back and in a position and a place where they are not really in the environmental set. So the where of the experience they have is not the where of their bodily set. But because the experience is the out-of-the-body experience is of the same kind of the normal experience, we have to see, as my hypothesis, that the where and the what of the body are not, in this case, the where and the what of the experience. So is so difficult that the where and the what of the normal and the out of body experience is something material, because so far and is too large in a sense, and our experience that is difficult can be thought realized by material stuff. I arrive now the most important fact that we can argue from my theories. In the article The Cartesian Set Theory, a unifying theory for mental disorders, I argue that the link between experience and brain functioning is in a sense correct, but correct for our contemporary thought about mental disease, but is not accurate the description of what happens. In every kind of mental disorders, there are a stop and block of neural circuits. They stop in a certain activity, and they don't go ahead to say correctly with is functioning. Where the block happens, where the circuit is blocked, there a kind of mental illness. This has a representation, yes, in the personal mind, but for what I exposed till now, in the experience in itself and in the way we are in the experience. So we can our behavior change and is blocked in a kind of behavior for every mental illness. For every mental illness. This happens for personal mind disease, and so for temporary and long hallucinations. The feature that I found for personal mind illness and the experience in the broader sense is the experience of detachment that regards a lot of other disease that has, for example, depression as a secondary expression. Detachment is the experience to be external to what happens in our experience. My theory is taught to experience to something that go is immaterial and go it is linked to brain in a way that we are in the experience as phantasms between phantasms as consequences about the about some new regards about the ego. Because the ego is especially in philosophy, an important role, and the metaphysic role of the subject that is a point in the human experience, a point, a special point of the subject, of the subjective experience that cannot be ruled out and is a part of every experience. For my theories, this is not correct. This is not correct because the ego, in this case, is simply that is cut from the entire experience of someone, the entire experience, and phenomena as proprioception and the feeling with the environment and the sense of distances from and differences from an object or for another person suffice to build a phenomenon like the ego. And there is not something that is only subjective, but the subject can spread himself in the entire experiences, as in the experiences of Alzheimer's patients and in Alzheimer's disease. What is important, and that experience as a construction that can be taught now in every kind of strange experience, because there is not that it is so fixed if there is not something as in the brain building as in the environment requests. This should be enough to expose what is my thought right now and to interest you about my work. Thank you for your attention. Best wishes.
Thank you for the wonderful.
Specifically, in this study, we explored whether pathway-specific genetic polygenic risk score, or GCPRS, would be helpful to predict treatment outcomes and inform for more personalized approaches to manage this complex condition. Bipolar disorders, or BPD, affects around 2% of the global population, and it's a condition characterized by recurring episodes of mania and depression. In addition to these mood episodes, patients may also experience cognitive and psychotic symptoms, which complicate the clinical picture. Despite decades of research, we still don't fully understand the underlying mechanism behind BPD. This lack of knowledge underscores the complexity of the disorder and is a hint of the likely presence of biological diversity among patients. This lack of understanding has a direct impact on treatment effectiveness, as many patients fail to respond to available therapies. Indeed, not all patients respond equally to the same treatments, leading to prolonged suffering and increasing healthcare burdens. As the reason behind this variability in response, as we said before, there could be the individual genetic background. For example, two patients with similar presentation, similar symptoms might have vastly different responses to a particular medication, likely due underline the biological differences. This variability highlights the urgent need for more personalized approaches to treatment, approaches that should consider the unique biological genetic makeup of each patient. With this in mind, we set out to investigate whether genetic data, specifically data related to biological pathways, could help us to predict treatment response. Our hypothesis was that by using a polygenic risk score, or to be more specific, pathway-specific gene score, as I will explain in a bit, we could better capture biology driving individual differences in treatment outcomes. With this data and leveraging on modern approaches for prediction, namely machine learning models, we could potentially be able to unravel the complex intercorrelation among these features and may be able to predict treatment outcomes. And in this work, we tried to test that. So I talked before of polygenic risk score and pathway-specific polygenic risk score. Let me briefly revisit this concept. So polygenic risk score is essentially a composite score that aggregates the effect of multiple genetic variants across the genome to estimate an individual genetic predisposition to a particular trait, in our case, BPD. While PRS can provide useful insight into genetic liability, it has some limitation. Indeed, a global PRS doesn't tell us much about the specific biological mechanism at work in a given patient. For instance, two patients might have similar PRS scores, but derived from completely different sets of mutation. This lack of specificity may reduce the information harbored by PRS, limiting its utility for treatment prediction. That's where GCPRS comes in. GCPRS, or gene cluster polygenic risk score, are essentially pathway-specific PRS. They are calculated by aggregating the effects of multiple genetic variants, similar to PRS, that are mapped to the genes of a specific pathway or ontology. The result is a composite score that provides a measure of genetic liability for a particular trait, but instead of being genome-wide like the PRS, it focuses on a specific cluster of genes. And this is where the GC-PRS differ from traditional PRS. A global PRS provides one single score for each patient, representing their overall genetic predisposition to the trait. In contrast, GC-PRS breaks the score down into multiple scores, one for each pathway or ontology considered. Using GCPRS would allow us to focus on the biological mechanism most relevant to the outcome we are studying in this case, potentially providing more information compared to standard PRS, which, as we said before, can miss critical details due to its broader scope. In other words, by narrowing our analysis to pathway level score and leveraging on machine learning model to account for complex interaction, we hypothesized to be able to capture a more detailed and biologically relevant picture, which could provide better insights into treatment response variability. Our study mainly used data from the STEP-BD dataset, which is one of the largest dataset of BPD to date. This dataset includes around 1,500 individuals diagnosed with bipolar disorder, whose characteristics are briefly summarized in the table. Regarding the symptom changes, they were collected at multiple times and using two widely used clinical scales, the Young-Manian Rating Scale for mania symptoms and the Montgomery-Åsberg Depression Rating Scale, or MADRS, for depression symptom. And we used these scales to assess improvement. So, regarding our analysis, we firstly focused on the pharmacologically relevant data of STEP-BD. In other words, we examined and collected the compounds used in treatment for these patients. From this information, we build with tools like Cytoscape, leveraging on dataset like String and Stitch. We build a gene network based on the interaction targets of such compounds. Once we compiled this network, we performed an enrichment analysis using the gene ontology biological process to discriminate the most represented ontologies within this network. To avoid the computationally intensive steps, we decided to focus on a subset of these key pathways. Specifically, we limited our analysis to the top 10 most represented ontologies, ensuring both efficiency and relevance in our approach. Once we obtained the pathways, we collected the genes within these pathways, or to be more specific, the gene locations, and used this information as filter to select the variants we will use for computing GC-PRS score. Specifically, we selected all SNPs located within the gene of each pathway, extending the region of about 5 kb, both on the 5' end and on the 3' end of the gene location to also capture regulatory elements. For GC-PRS calculation, we also needed another information. To avoid using the same data set, which could have caused a bias in calculation and in the following modeling step, we used the give us summary statistic of another set, the PGC-BPD dataset, to retrieve the effect size of the SNPs. So, to calculate the scores, we optimized and filtered the data from this second database, which included the quality control, SNP filtering based on the data of the step D, after adequate adjustment related to the different assemblies of the two datasets. And we then calculated the GC-PRS using tools like P-Link and combined the SNPs and the effect size to compute GC-PRS for each pathway and each participant. So in the end, from all the genetic data from STEP-BD, we translated in 10 score, 10 GC-PRS for patients. The GC-PRS scores, combined with clinical and demographic data, were used as input feature for a neural network model designed to predict outcomes. The neural network consisted in two different input layers for categorical and continuous feature, name shared hidden layers with the number of nodes ranging from 19 to 32, and separated output layers for continuous categorical outcomes. The target variables we checked was improvement, intended as the percentage change of YMRS and MADRS score, compared to baseline. This variation was also encoded as categorical, with improved, worsened. It was also calculated by the model. Finally, we used the standard metrics as shown in the slide to evaluate the model. To note, all variables used were normalized for continuous variable or one-hot encoded for categorical variable. And regarding validation, we used the five-fold cross-validation on the training set as a validation step. So, from the pathway analysis, we will build a pharmacological network and selected the top 10 biological processes enriched in this network. To be fair, in reality, we selected more than 10 biological processes, as you can see on the table on the right-hand side of the slide. And fused them based on their degree of overlap until we reached a total of 10 gene clusters. We then obtained this cluster, including among them we have neurotransmitter signaling and compound metabolism pathways. And these pathways, as we said before, were used to calculate the GCPRS scores for each patient, and formed the genetic basis of our predictive model. Regarding the modeling step, unfortunately, the model's performance we obtained was rather limited. As you can see, the accuracies in the last column of the tables, we obtained pretty low accuracies, both for YMRS, MADRS, and the categorical improvement we tested. Indeed, the best we achieved was around 50% in predicting categorical improvement at 9 months, which was not statistically significant. But this data suggests that while GCPRS scores might be biologically informative, they are not sufficient on their own to predict treatment outcome in BPD. Despite the robust selection of pathways implicated in compounds action, their cumulative genetic contribution was not sufficient for accurate prediction. This findings highlights several challenges for a robust model of BPD treatment. In particular, our results indicates that the key feature influencing a treatment response, whether genetic, clinical, or environmental, may be still missing for our model. Also, model limitation, the limited scope of the pathways considered, and the inherent variability in treatment regimens across the study population may have contributed to the low predictive accuracy of our model. Looking ahead, we plan to modify and expand our analysis to include additional pathways, as well as environmental and epigenetic factors, and also stratify patients into more homogeneous subgroup based on treatment that could help reduce variability and improve model performance. To be honest, we already have some preliminary data in which we observed some promising improvement in accuracies up to 30% in some cases by including features like sample source and medication filtering. While these results are interesting, they require however, they require further validation in independent datasets. But from this, we opt to further tune our model. So, To conclude, our study underscored the challenges of predicting treatment response in a complex and heterogeneous disorder like bipolar disorder. And while GCPRS score might offer a step forward, they are not yet sufficient for clinical application. Future research must continue to refine models, expand datasets, and incorporate additional biological and clinical features to achieve truly personalized medicine. Thank you for your attention, and I'm happy to take any question.
What I'm going to talk about today is why I'm here, and it's my personal story. Parenting a child with ADHD and LD. Do you see the slide?
Yes, we see the slide. Could you put it on the slideshow mode?
You see the slide, please?
Yes, but not in full view. Could you click on the slideshow icon? It's at the bottom of the screen.
I saw it as a full screen. I don't know why you don't see it as a full screen. I'll try it again, please. Can you see it now full?
Yes, we can see it now.
Okay, thank you very much. So what I'm going to talk about today is why I'm here. It's my personal story. How difficult is parenting a child with ADHD and LD? The school system, how it deals with these children, and how many difficulties as parents we have about it. What is the coping mechanism about dealing with these children? Methodology of my two studies, results, and on the other end, a follow-up research. So why I am here? As the mother of a son diagnosed with ADHD, I have experienced considerable frustration with an educational system that often lacks the necessary resources and strategies to effectively support those children. I fought for my son to raise him as a success adult, enabling him to develop as a diligent individual who contributes positively to society. From a frustrated child, he transformed to a talented adult. My son is now 32 years old, an AI engineer, and surrounded by a supportive family and friends. If I hadn't been there for him, it might look differently. This gifted event brought me to a postdoc and specialized in ADHD and LD children. As a mother in the education system, I understood the difficulties of parents dealing with challenging child alongside system that doesn't always provide effective solutions. Today, I'll present two studies that illuminate both experience with this context. Study number one, how frustrating it can be. It's a qualitative study. 12 parents shared with me their experience about raising challenging ADHD and LD children. This study provides valuable insights into complexity of parenting in such circumstances, highlight both the emotional and the practical dimensions of parent journey. How difficult it can be raising a child with ADHD and LD. One mother told me, It's hard and required a lot of patience to be a parent of a child with ADHD. To be there all the time to help so that he doesn't forget the school brochures, that he doesn't forget to take his water bottle, that he doesn't forget to eat, that he knows to prepare his homework. It can be really exhausting and frustrating. Another mother told me, I don't understand why I must do everything for him. Why he can't be independent like other children. I am tired of being the one who keeps asking her to come to do her homework, sit next to her, why she can't do it by herself, when she will be independent. These difficulties made me to increase these difficulties led me to increase resilience to others and reduction of its confidence. Parenting a child with difficulties or disabilities is not a simple task, especially as parents often become frustrated with their children who differ from other children of the same age. This study explores how parents of children with LD and ADHD address their children's challenging and their perception of educational system, employing qualitative methodology and semi-structured interviews. The research investigates the strategies parents use to manage their children's difficulties, as well as the views of the intervention and support provided by the school system. Data analyzing study number 1, how frustrating it can be, qualitative study. The research population were 12 parents of students with LD, ADHD at the age between 28 and 44. The research tools were in-depth semi-structured interviews. Part A of this interview was a demographic questionnaire, and part B was open questions. The qualitative data was conducted through a coding process stages: open coding, vertical coding, and selective coding. Each of the stages promote us to identify the main themes. The 4 main themes that arose from the data was absence of structures and systematic information, influenced insufficient guidance and effective coping strategies. Disappointment from performance as parents, disappointment from education system. Dependent children who need help, concerns regarding these children's futures. This study also implemented context analysis of identifying and analyze central themes that stem from the text. After identifying these themes, we constructed a theoretical model connect between these themes and existing theories. Theme number 1, absence of structure and systematic information. Lack of organized information regarding LD and ADHD. Most of parents talk about being not able to provide their children with the necessary assistance about their the LD and ADHD problem and their lack of knowledge. I not only, one mother told me, I know a lot of parents who aren't familiar with the terms of LD and ADHD and don't even know that they can get some support. That's why some children don't receive all the help they need because their parents aren't aware. I feel sorry for parents who don't know. Theme number 2, disappointment from performance as parents. Most of the participants, 12 out of 14, discussed feeling of disappointment due to the gap between their own experience and their children's difficulties. AM, a mother of a 6th grade son with dysgraphia and ADHD, told me, parents always expect their children to be perfect. The child's success is their success. When I found out that my child is not perfect, that he has difficulties, I felt like I was a failure. What a disappointment. I had invested so much and all was for nothing. BB, it's a father of 10 years old son with verbal learning disabilities and ADHD. Raising a child with LD and especially with ADHD is extremely difficult. I was overcome by feeling of disappointment. I felt I have not fulfilled my role as a father to raise a successful child. A son, as soon as my boy was born, I imagined him growing up to be the best student at the school. And later, I imagined him as an engineer, doctor, or a lawyer. When I received the results of the assessment, I felt sad. I felt that I couldn't cope I couldn't cope with it. Only someone who has gone through this can understand what I'm feeling. Disappointment from education system. The parents also express challenges, meaning the demands imposed by schools. Analyzing the interviews reveals that criticism on expectations placed by education system. Many parents highlight the impact that schools place on grades, arguing that this narrow focus on academic performance fails to actually reflect their children as children's true ability and potential. AZ, a father told me, also discusses this aspect. It's really important to let children with learning disabilities know that grades are only secondary. They don't have low grades because they are lazy or don't work hard. The education system places grades and places a great emphasis on grades and criticize our children accordingly, and it is not fair. Theme number 4. Dependent children who need help. The parents in this study also discussed their worrying about their children and the difficulties they will face in the future. The parents described their emotional difficulties when they constantly see their child failed, sad or different. Many parents also express their own emotional difficulties in constantly having to provide overcoming and support. My main difficulties is seeing my child feel sad and disappointment because of his academic difficulties and low achievement. I often think about what his future will look like. In today's day and age, higher education is necessary. Follow-up research. After 3 or 4 years, we made the follow-up research. Is a qualitative research with students that are with ADHD and LD, and they are talking about their parents' support. In the follow-up study, we examined the effect of direct involvement of parents of child with LD and ADHD at school as factor of affecting the student's success and the ability to function in school and in academy. The research show that parental involvement plays a crucial role in children's development, particularly for those with learning disabilities. The strength of this condition can influence key factors such as self-efficacy, academic performance, and emotional well-being. Studies suggest that children whose parents are actively engaged in their education, providing support for learning at home, and offering emotional guidance, tend to cope better. This type of parenting fosters the supportive network is important for children with learning disabilities. What is an involvement parent? Establish collaborate relationship between parents and the educational system with the focus on developing mutual agreed upon framework, and the shared language is essential for effectively supporting students with LD and ADHD. The relationship between parents and teacher encourages the children to feel that they are part of the large system that support them, and that the parents are essential part of the learning process. The sense of belonging is a result of this involvement. It develops a positive self-image as a stronger sense of ability to face the educational challenges. Sorry. Okay. Follow-up research. In the qualitative research, we have 56 students with LD and ADHD. The age was between 20 and 29 years old. almost 65% of them reported that their parents were involved during the high school and helped them to cope with the challenges of the education system. The research tool was a closed Likert scale attitude questionnaire that included Part A demographic questionnaire, Part B three key indexes, parental involvement, emotional and functional support, parental involvement, belief in abilities, and operation efforts. Part C, student academic ability, self-esteem, and function. Follow-up research.
Interrupt your presentation, but we can't see the actual slides.
You can see the slides. Okay, I'll try to do it again.
Okay.
Do you see it now? It's okay?
Yes, we can see it now.
Okay, thank you. So I'm
sorry again. Could you put it on full view?
It's on view. You can see it.
We can see it, but it's not full view. Could you click on the slideshow icon?
I'll do it again, please.
Okay.
Is it okay now?
It's okay. It's okay. Thank you.
Okay, thank you very much. So I'm talking about the follow-up research, a qualitative study, means and standard deviation of the research indexes, the impact of parental involvement on learning. A significant positive correlation was found between the level of parental involvement in the learning process of students with learning disabilities and ADHD during school and self-efficacy perception of the students in the academy. Impact of the involvement of self-efficacy perception. Significant positive correlation was found between the level of parental involvement during learning in school and the ability to conduct the learning process and the level of academic performance of students. Discussion and conclusion of study number 1. The study demonstrated the difficulties of parents who are coping with LD or ADHD children, the important role that the involvement of parents in the education system plays, and its significant role assessing these children. The findings presents the importance of providing information to parents for dealing with their children, academic difficulties, and enabling a fruitful cooperation between parents and school. The parents in this study also emphasize the importance of social and emotional aspects of their children's lives and how school must provide emotional support and enhance the children's self-ability. Wow, sorry, why? It can be different. Study number 2, the main finding emphasized the main role of parents' support for their LD and ADHD children as a lever to promote them to academic and fruitful life. The follow-up study shows the crucial importance of parents' involvement and assistance in the students' learning and academic performance. Student self-efficacy perception in later stages of their lives. The research findings clearly show that there is a clear positive correlation between the level of parental involvement in the learning process of students with LD and ADHD and their sense of ability and academic performance. Parental involvement is a significant competence in the development of self-efficacy and academic functioning of the students with LD and ADHD. This involvement not only provides students with tools to deal with educational tasks, but also strengthen the sense of security, support them emotionally, and shapes their perception of their ability and success in the future. I would like to thank you, and I will be happy to answer the question if there are any. Thank you very much, Dr. Anat Raviv.
Thank you for your presentation. If anyone has any questions,
I would like to thank the organizers for inviting me to share our research with you today. Our research explores diagnostic transition from primary psychiatric disorders to underlying medical conditions based on a 5-year retrospective analysis conducted at a university hospital. As you can see here, this slide shows the structure of my presentation. If you get distracted, you can follow the boxes above. Symptoms of mental illness can sometimes be an early indication of underlying medical conditions rather than purely psychiatric disorders. When unnoticed, medical issues can cause misdiagnosis, delayed treatment, unnecessary psychotropic use, and complications. According to the DSM-5, when psychosis is linked to a medical condition, it's called psychotic disorder due to another medical condition. Studies show that 5% of first episode psychosis, often resembling schizophrenia, have a medical cause, highlighting diagnostic challenges. Recognizing these cases sooner can make a big difference in getting patients the right treatment at the right time. Many conditions affecting the CNS, like metabolic, infectious, toxic, neurological, and endocrinological disorders, can first appear as psychiatric symptoms. With this context, we can continue with the objectives of our study. The purpose of this study is to investigate cases where a primary psychiatric disorder was later found to be caused by an underlying medical condition. We focus on understanding the prevalence, sociodemographic and clinical characteristics, and how initial diagnosis changed to final diagnosis in these patients. Next, I will explain the methods we use to collect and analyze our data. This is a retrospective and descriptive study was conducted at Gazi University Hospital in Ankara, Turkey, one of the largest academic hospitals in the region. And it includes patients treated at the psychiatric clinic between 2015 and 2020. We gathered data from clinical notes, laboratory tests like blood counts, liver and kidney function tests, vitamins, and imaging like CT, MRI, PET, EEG, and neuropsychological evaluations. The files of a total of 1840 patients who were hospitalized in our clinic, which is divided into male and female wards, over a 5-year period were examined. We evaluated diagnosis using DSM-5 criteria, but for consistency across all cases, ICD-10 codes were used in the records. We are using ICD-10 codes currently in our country. Patients with suspected diagnosis were re-evaluated during general meetings with the participation of all faculty members. If an underlying medical condition was suspected, consultations were requested from relevant departments, such as neurology, neurosurgery, physical therapy, or endocrinology. In this study, we included patients who had previously been followed up with a primary psychiatric diagnosis, either in our hospital or another center. Patients with insufficient data for analysis were excluded from the study. If you look at the variables, we analyzed some key variables such as sociodemographic characteristic, initial psychiatric diagnosis, final diagnosis, age at first diagnosis, hospitalization history, number of hospitalization, drug usage, and the time to identify underlying medical conditions. We only used descriptive statistics, and all analyses were performed using SPSS. Since this study is retrospective, informed consent was not required. And results section, I will present the findings from our analysis. Out of 1840 patients initially diagnosed with a primary psychiatric disorder, 1781 retained their original diagnosis. However, 19 cases transitioned to another primary psychiatric disorder, and 30 cases were later found to have an underlying medical condition. In the results section, we focus on the 30 patients whose diagnosis transitioned. The ages of these patients ranged from 19 to 82, with a mean age of 46 years. And if you look at the gender, of the 30 patients, 2/3 were male and 1/3 were female. And this result is important, I think. It took an average of 5 years for these patients to receive a clear diagnosis, final diagnosis. The length of stay during the last hospitalization, when the diagnosis became clear, ranged from 40 to 81 days with an average of 1 month. Generally, patients stay in our clinic about 1 month. Of the patients, nearly 2/3, 63%, experienced one prior hospitalization, while 23% had never been hospitalized and 13% had 2 or more hospitalization. And this hospitalization can be another center or our clinic. We found that 76% of the patients, or 23 out of 30, had at least one previous psychiatric hospitalization before their final diagnosis was made clear. 90% of patients used psychotropic drugs, and highlighting their dominance before identifying medical causes. These patients, non-psychotropic drug use and follow-up without a medication, these patients were depressive patients diagnosed with depression, and their treatments were CBT. And we see in this slide, we see the distribution of psychiatric diagnosis among the patients. Depression was the most common diagnosis, accounting for 40% of cases. And this was followed by schizophrenia at 30% and functional neurological symptom disorder at 10%. And this slide illustrates the average time taken to clarify the underlying medical condition for each initial psychiatric diagnosis. For depression, the mean time was 3.2 years, while schizophrenia required an average of 6.5 years. And that slide presents the underlying medical conditions identified in our study. As you can see, Alzheimer's disease was the most common, seen in 16% of cases, followed by space-occupying lesions at 13%. And this slide provides a breakdown of the underlying medical conditions observed in patients diagnosed with depression and schizophrenia. Among depression patients, dementia was the most frequent, with Alzheimer's disease accounting for the majority. And on the other side, the conditions were more diverse, like traumatic brain injury, stroke, Behçet disease, space-occupying lesion, syndrome chorea, encephalitis, and hydrocephalus. This chart illustrates diagnostic methods utilized during the process of revising initial psychiatric diagnosis. MRI and blood tests were the most frequently used tools. Among these, abnormal findings, red boxes, abnormal findings were notably higher in MRI scans, accounting for 24 cases, and in blood tests with 11 abnormal results. EEG and neuropsychological tests also contributed to identifying abnormalities, but to a lesser extent. And now we move on to the discussion section. As I said before, depression and schizophrenia were the two most frequent initial diagnoses. And this emphasized the importance of being vigilant for underlying medical conditions, particularly in cases initially diagnosed as depression and schizophrenia. This slide illustrates the transition from 8 different initial psychiatric diagnoses to 19 final diagnoses after considering underlying medical conditions. It underscores the complexity of such cases and the importance of a comprehensive diagnostic approach. The frequency of transitions from primary psychiatric diagnosis to underlying medical condition in this study was 30 out of 1830 patients. This represents a lower rate compared to data reported in the literature. And it could reflect differences in diagnostic practices, patient characteristics, or methodologies. Psychiatric symptoms at unusual ages may signal organic causes, yet even typical presentations can hide underlying conditions. Delays in diagnosis, postpone treatment, harm well-being, increase psychotropic use, and raise morbidity. This highlights the need for early and accurate diagnostic practices. The average onset age of 27 years aligns with schizophrenia norms, emphasizing the need to rule out medical causes during initial evaluations. In older patients diagnosed with depression, it's common to consider dementia as a possibility. For younger individuals, conditions like early onset Alzheimer's disease should also be kept in mind, even though they might be less obvious. Overlapping symptoms and shared risk factors between depression and dementia can make it challenging to differentiate between the two. In a meta-analysis study, the prevalence of clinically significant neuroradiological abnormalities in first episode psychosis was estimated to be 6%, and the number of patients requiring screening to detect one clinically significant abnormality was estimated to be 18. Based on these findings, the routine use of MRI as part of the initial evaluation in patients presenting with first episode psychosis has been recommended. As opposed to MRI, CT studies examining radiological abnormalities in patients with psychosis have produced estimates that are considerably lower. This observation can be attributed to CT's comparatively low sensitivity in identifying intracranial abnormalities among individuals diagnosed with psychosis. Neuroimaging techniques such as MRI and CT play a crucial role in clinical practice. especially when diagnostic uncertainties arise. Their application can provide clarity and assist in identifying underlying conditions, enhancing patient management and outcomes. Our study's strengths include the comprehensive analysis of all psychiatric diagnoses, not limited to specific ones like schizophrenia or depression, ensuring a broader perspective. Additionally, the inclusion of a substantial time frame of 5 years allows for a more robust evaluation of diagnostic changes over time. Psychiatric symptoms can signal medical issues. Multidisciplinary teams, especially psychiatrists and neurologists, ensure accurate diagnosis. And limitations. Our study faced several limitations. The first one, the small sample size limited the statistical analysis to descriptive methods only. And medications used were not evaluated in detail. Psychiatric symptoms in epilepsy patients can result from the condition itself or side effects of epilepsy medications. For certain neurological disorders can provoke psychiatric illnesses, and the reverse has also been observed. The study was restricted to diagnostic changes that occurred during the hospitalization period. Lastly, to sum up, this study shows the importance of checking for medical conditions in patients with psychiatric symptoms. Diagnoses like depression and schizophrenia may sometimes hide an underlying medical problem. This reminds us that teamwork between psychiatrists, neurologists, and other specialists is crucial. Using tools like MRI can help find these hidden conditions, especially when there is doubt about the diagnosis. Early and accurate diagnosis can improve treatment and prevent unnecessary side effects. Although the study has limitations, it highlights an important issue in psychiatry. We must stay alert and work together to provide the best care for our patients. Thank you. Thank you for your attention. For any question, please feel free to contact me. I will write my email address in chat box.
Thank you, Doctor. If anyone has any questions,
My project, my work about the genetic link between the trace element and psychiatric disorders. As all we know, psychiatric disorders are complex, multifactorial diseases. They are characterized by disturbance in thought, mood, or behavior, and represent a significant global public health concern with an increasing number of individuals affected worldwide. It is estimated in 2019, approximately 970 million people, that is equivalent to 1 in 8 individuals globally, were living with a mental disorder. Many psychiatric disorders commence in childhood or adolescence, and comorbidity among these disorders is common. Over 50% of the population in middle and high income countries experience at least one mental disorder during their lifetime. The etiology of this disorder is multifaceted, involving genetic factors, environmental, and neurobiological factors. About genetic factors, we can say that they play a significant role in common mental disorders, such as, for example, schizophrenia, bipolar disorder, and mild depressive disorder. Research has identified both specific and common genes that are implicated in these disorders, suggesting that
shared an unique genetic mechanism contribute to their onset risk. Additionally, it's really important to note that exposure to environmental stressors such as, for example, pollutants, smoking, and the nutritional deficiency has been strongly associated with the onset and progression of these disorders. Moreover, recent data suggests that also epigenetic factors play a significant role in the etiology of mental disorder. It seems to be a complex genetic alteraction that induces stable change in gene expression and the neuronal circuit function. Such change can affect the central nervous system during, for example, development and adulthood. Currently, there are, for all these reasons, there are a lot of limitations in both diagnosis and treatment, probably because in general we can say that there are disorders overlap, treatment resistance, and the lack of biomarkers for an earlier diagnosis. Important, as I said before, is the environmental factor rule. As I said, the exposure to environmental stressor has been strongly associated with the onset and progression of this disorder. In particular, we and in general in the last period, the research has increasingly focused on the role of trace elements. Trace elements are essential micronutrients present in the human body in minute quantities, but they play a crucial role in various physiological processes, including neurotransmitter synthesis, oxidative stress regulation, immune function and regulation. Recently, in general, World Health Organization has long recognized their role in human health, establishing that altered levels of essential or potentially toxic trace elements can lead to pathological conditions, including psychiatric disorder. Indeed, some studies highlighted a correlation between the trace element imbalances and psychiatric disorders. These elements can be classified based on their nutritional significance, and we can classify as nutritionally essential, presumably essential, or potentially toxic. And we have to know that essential and presumably essential elements primarily serve as a catalyst in various biochemical reactions, aiding enzymes and protein in their function. This function in turn can influence numerous processes such as growth, development, cellular regeneration, metabolism of sugar, protein, fats, cellular respiration, response to oxidative stress, and so on. So these elements can directly interact with the cellular process. For example, it can interact with the ion channels of the cell membranes, modifying their structure and indirectly affecting membrane trafficking and so membrane permeability. It is really delicate, the balance required for maintaining optimal trace elements levels in the body, as alteration can result in significant clinical manifestation and the pathophysiological state. The balance of trace elements within the body is closely linked to genes and protein that regulate their intake and concentration. At the time, for our knowledge, no detailed study tried to factorize the trace element dysregulation and risk variable in psychiatric disorder. For this reason, our idea, sorry, I have to move this one. For this reason, our idea is to exploring the genetic background that acting trace element metabolism may provide further insight into the mechanism underlying psychiatric disorder, identifying specific relationship between trace element associated molecular pathway and the genetic underpinning behind psychiatric disorder may better clarify the etiopathogenesis and lay the foundation to develop a new targeted intervention and personalized therapeutic approach. This in silico study, this is an in silico study, is part of a greater project that want to try to tackle this knowledge gap and evaluate the trace element rule in psychiatric disorder. So the aim of this study is evaluate the degree of overlap existing between known genetic risk factor in psychiatric disorder and genes whose products are involved with trace elements metabolism. To do this, we have proceeded through 4 different steps: literature, meaning custom pathway building and aura, pathways cross-linking, and validation. For the first step, through literature meaning, we retrieved a list of genes associated to process involved in trace element metabolism like absorption, transport, storage, mobilization, excretion, and the latest data and a list with the latest data on genetic risk factor of psychiatric disorder. We have used this list for the second step as a foundation for custom pathway building and over-representation analysis. Highlight significantly overrepresented pathway ontologies based on gene ontology, in particular biological process, cellular component, and molecular function, and based on reference pathway dataset, in particular KEGG and Reactome. Pathway cross-linking leverage on the pathway associated with psychiatric disorders and trace elements and highlights common element potentially representing the cross-link between the pathologies and the trace element. At the end, the validation, in which the intersection of genes and pathways was validated from give us summary statistic from public data set obtained from the Psychiatric Genetic Consortium, in particular bipolar disorder of 2021, neurodepressive disorder 2019, and schizophrenia 2022. What we obtained from this, and it is in this like flowchart chart, you can see all these 4 steps in which we have literature meaning with gene sets of representation analysis, ontologies interaction, and validation step with give us summary statistics. What we have obtained from literature meaning step, we retrieved the aggregated genes which have been associated with the investigated trace element and the genes related to psychiatric disorder. The constraints of the search were remained lax, I want to precise, to include all possible related genes, to increase the number of the genes. And as you can see, we obtained 7,343 trace elements related gene, 974 bipolar disorder related gene, 535 MDD, mild depressive disorder related genes, and 1,912 schizophrenia related genes. Here you can see the graphs reports the top significant pathway ontology found for each gene set analysis. Using this in the following step, we evaluated among the significantly enriched pathway which once result shared among trace element related pathway and each of the pathological condition investigated. Thanks to this cross, if you want, you can see the overlapped pathway between the considering bipolar disorder disease, mild depressive disorder, and schizophrenia. We have the number of shared pathway ontology between trace elements and psychiatric disorder, and taking in consideration also in this case, obviously, biological process, cellular component, molecular function, KEX and reactome. Applying stringent filtering based on p-value and intersecting the data from GIVAS with the pathway obtained in the previous step, we obtained a list of pathways that not only are reached in variants related to psychiatric disorder, but are also likely involved in trace element function in the body. In details, as you can see in this slide, in these tables, we observed that the gene ontology, molecular function, voltage-gated calcium channel activity, height voltage-gated calcium channel activity are gene ontology terms shared between trace elements and bipolar disorder. The reactome, this one. Also interesting is the reactome pathway detoxification of reactive oxygen species is shared between trace element and schizophrenia. But the more, in my opinion, the more interesting results is this one, which the KEG pathway, gonadotropin releasing hormone secretion, is shared between the trace elements and all the psychiatric disorder we have taken in consideration. In addition to the validation, the pathways road validation was also carried out on the list of genes. In particular, since there are many, we decided to validate the results obtained from the comparison between the list of trace element genes and pathology without considering the pathways, only the genes. Both the entire list and the list of the top 100 most important genes showed the same results. In table, you can see, the table shows shared genes, and we can see significant with schizophrenia. This study highlights the intricate connection between trace elements, metabolism, and psychiatric disorder, emphasizing shared molecular and pathway levels mechanisms. Validation with GIVAS datasets support the significant overlap of trace element-related genes, particularly in schizophrenia. Really interesting is, in particular, as I said before, the shared pathway of gonadotropin release hormone, for example. In a general, positive result with the evidence genes constituting the connecting link between psychiatric disorder and trace element metabolism, potentially supporting the rule for trace element in psychiatric disorder and providing the basis for new potential approach in psychiatric disorder risk prediction and monitoring. Also interesting is that recognizing the importance of trace element genes expression as a factor influencing psychiatric symptomatology may help tailor treatment and support new strategy. This study, as I said, is an in silico study that presents strengths and criticism and several limits. Strengths: first, comprehensive approach combining literature meaning, pathway analysis, and GIVAS validation. Second, clear identification of shared and disorder-specific pathways. Third, use of different dataset enhances robustness and reproducibility. Obviously, there are also several limits that regard gene selection, path analysis, validation, focus on cross-disorder insight. For gene selection, reliance on literature means that genes may introduce bias, complemented with unbiased data source, for example, RNA sequence or proteomics. Pathway analysis of overrepresentation analysis can be sensitive to input genes lists and reach result with additional methods like ISEA or network-based pathway analysis. Give us, for the validation, give us data set that are robust but represent association, not causation. Functional studies to validate KNG's pathway would strengthen conclusions. Focus on cross-disorder insight, explore cross-disorder mechanism more thoroughly to understand shared versus unique molecular signature. As I said, this is part of a project that is developed that want to arrive, that has like a finally goal to develop a risk and treatment profile for psychiatric domain. The project is named PTORIT. The goal of this study is to correlate genetic profile, trace element levels, and psychiatric symptom cluster, enhance personalized medicine through targeted prevention and treatment strategy. We will use innovative approach like machine learning application, and we hope to obtain interesting result to share also with you next time. Thank you very much for the attention, and again, thank you to the committee for this opportunity. For any question, you can send an email to the email that I write on the chat box. Thank you.
Thank you for your presentation. If anyone has any questions, can you please turn on your mic and directly ask? Or you could also drop it into the chat.
Psychoanalysis application in the kayak test and the evolutionary test. These approaches are based on my doctoral thesis dissertation focused on Melanie Klein's model, and also this model is based in my experience as a professor in Barcelona University about evolutionary psychology. And this work has this result in this model, the kayak test model, evolutionary model, but based in a initial idea of Melanie Klein's psychoanalysis. This is my scheme of my presentation. This basic concept of Melanie Klein's theory, very briefly. The idea of the two positions, paranoid schizoposition, related to fear of being annihilated, and depressive anxiety with the fear that the self and good objects are destroyed. That's perhaps the more basic idea of the model of Melanie Klein. The idea that the mind is structured an initial process of projection of impulse, and after the introjection of new objects related to the relationship with the mother or the parental figures. The idea that the mind is structured for maturation in contact with reality, but the initial mental function is the fragmentation. After there are a process based in dissociation, and after it is possible the integration. The kayak test is based in this idea of the importance of fragmentation of reality and the dissociation of reality in the mental functioning. After we'll explain. Freud emphasized the idea that the libido seeks pleasure. Melanie Klein thinks that the libido seeks the object, the relationship. Is a model very based in the relationships as a basic structure of mental functioning. The idea that the fragmentation, the dissociation, and after the repression are the process that are related to maturation of the mental functioning. And finally, is very briefly, the idea, the importance of transference in the treatment. The idea that the transference is the most important way to entry in the mental functioning and to develop the treatment. Very briefly, these ideas, basic ideas of Melanie Klein's model. This is the consultation of Melanie Klein in London. She worked in the city of London. The second point is the five basic concordance between evolutionary theory and Melanie Klein theory. The evolutionary theory I not will explain now because it's most new. I directly will enter in the analysis of this concordance that I think that there are very important. The first concordance is the importance of relational life in the structure of mental functioning. From the perspective of evolution, evolutionary psychology, it is suggested that the complexity of the human brain and mind is related to community life in very complex societies. Dunbar proposed the group about 150 members, a very complex group for the relationship, and we need a very big brain, a very complex mind for structure this relationship. This is the same idea of Melanie Klein. All the mental functioning is structured fundamentally for the relationships, for shares, aliments, for survive in the nature. Is not necessarily a very big brain. A lot of animals don't have a very big brain and live perfectly. But our social life is extraordinarily complex, and we need an extraordinarily complex brain and mind for living in community. We have a very big brain related to extremely complex social life. This evolutionary idea, but the Melanie Klein idea is the same. The second concordance is the mental disorder will be fundamentally a maladjustment in relation with the community in both models. I am referring to mental disorder, no neurological disorder. No. Mental disorder related in the two models with the extreme complexity of human relationships. The third concordance is the importance of children games, very important in the maturation, in the evolutionary model, and also is the basis of the treatment in the work with children in the Kleinian model. The importance of the game in the children for the maturation and the structuration of the mental life. The fourth concordance is both theories consider that the mental life in the baby is active and point out the relevance of the fears for survival in the children. The evolutionary model until the idea of the difficulty of survival of the children, and Melanie Klein also has the same idea and explain the intensity of fears of children related to difficulty for survival from a personal perspective. The immaturity is very, very important, and this situation of dependence of the children is related to extreme fears. And the two theories explain the same situation of fears for the children. Melanie Klein considered that the difficulties also for managing these emotions, intense emotions, are very difficult to manage. And the five concordance, the evolutionary model with the cooperation competition theory, and the Melanie Klein model with the envy gratitude model. There are, for me, concordance between the two models. This is the second part, and the third part is a test that I developed utilizing these two theories. The kayak test. The kayak test is a schematization, a model based on the evolutionary theory for the studying, initially for the migration mourning. I am specialized in migration and mental health. I developed the concept of the Ulysses syndrome, extreme migratory mourning living today for millions of migrants in all the world, related to extreme situation of solitude, forced separation, fear, terrible situation for millions of migrants. I developed this model specifically related to migratory mourning, but it's a model that perfectly can be utilized in other contexts, difference of migration. The kayak test represents the functioning of the mind with a scheme. This scheme goes from the simple to the complex with a deductive approach. It starts from some basic premise represented in two axes, very elementary in mental functioning. These premises are developed and made more complex. The two axes, the first axis is axis of activity. Is mental activity and activity related to relationships. Is not only the activity for the construction buildings, or is a activity more related with the contact with reality, with the activity. And in this axis is a very basic concept. There are the idea that there are a dimension related to activity, a dimension with two extremes, a extreme of no activity, depression, passivity, and the other extreme of extreme activity, mania, euphoria, and in the middle was a normal functioning, integrated activity. This is the first axis, very intuitive, of this model of kayak test. But I consider that there are other axes related to direction of activity. It's not only important to have energy or activity, it's very important also to understand the direction of activity. And I consider, and this idea is based in the Kleinian model, that there are two directions related to activity. And this is very concordant with the evolutionary theory. From evolutionary theory, there are two directions in action: exploration to share resources and protect the resources. There are the two more basic functions on its nature: exploration and security. But the extreme of exploration is the chaos, and the extreme of security is the paranoia. It's the same idea that in the other, in this axis, the extreme is problematic, and in the center there are the integrated and functioning with capacity of relationships. And in this other axis is the same idea. Two extremes, problematics, pathologicals, are in the center the capacity to have a relation, a good relation with the reality and with other members of the community. This is the second axis, the area of searching for resources to survive, and the security, defend ourselves and respond to attacks. Obviously, we cross the two axes, and we can see, we can see that there are in the extreme, I explained, there are this pathological situation, and we cross the two axes, and we can develop this model. For Klein, the mental life for the infants is highly polarized at the extreme of the axis. And for Klein, the idea is that there are very important the dissociation and the fragmentation. And Klein also speaks about the depressive position, is very new, but my doctoral dissertation was about the theory of Melanie Klein, and Klein adds other position, the manic position, but after Melanie Klein refused this idea. But I think that this idea is interesting. Interesting. Melanie Klein, in the work in the 40s, developed the idea of the manic position, but after considered that it's not necessary this position, and explained that there are two positions, paranoid schizo position and depressive position. But I think that is interesting also to maintain this idea of the manic position. The kayak test is based in this idea, the two axes, manic, depressive, dissociation, and in other extreme, fragmentation is based in the Kleinian model. There are texts about the concepts of Melanie Klein about manic position, but these ideas after were refused for Melanie Klein. There are the texts in which Melanie Klein developed these ideas. And my idea is that there are one axis, mania, depression, and the other axis, exploration, security, is in Kleinian theory, axis fragmentation, dissociation. The dissociation is fundamental in paranoia, good, bad, two elements, but in the fragmentation, in the other part, there are an extreme number of elements, and there are the chaos. There are the impossibility to contact with reality. The two mechanisms are defensives. There are two defenses related to anxiety in the Kleinian model. And I developed this idea related to an evolutionary model. And we cross the two axes, and we can see four mental basic functioning: action, security functioning, action, dissociation functioning, passivity, security functioning, passivity, dissociation functioning in Kleinian language. In the other part, passivity, exploration functioning, in the extreme, passivity, fragmentation functioning in Kleinian model, and action, exploration functioning. There are the consequence of the cross, the two axes. And we can see the application of the Kleinian model to evolutionary model, the combination, the two models. And we can see the four functionings. We can see the action security, the activity is polarized to action, but in the passivity security functioning, the activity is polarized to resire, to isolated functioning. In passivity exploration, the activity is inhibited, and in the action exploration, the activity break limits, go far. There are four very basic mental functionings, and this idea is based in this Kleinian evolutionary model. The idea is that in the center, there are the integrated levels, and in the extreme, the psychotic level, in the center, the neurotic level. Mania, depression, paranoia, fragmentation related, for example, for the schizophrenic functionings. And we can see these four basic functionings: activity, security, passivity, security, the isolation, the culpability, functioning related to no-go to relationship with the object. And this, the same idea related to other functionings. And we cross the two axes, and the two axes is related to the existence of these four basic functioning related to connection between action and direction of the action, the two basic directions are exploration and security. And developing more this model, we can see a basic adaptive functionings, adaptive control, adaptive assertivity, adaptive withdrawal, adaptive self-criticisms, rethinking, rest, exploration, and action. There are, in the center, there are the adaptive member. Are not extreme dissociation, are not extreme fragmentation, are capacity to see the reality with complexity, but without chaos, and without dissociation, good, bad. And this is developed based strictly in the connection with the two axes, energy action axis and direction of activity axis. And developing more this model, we can see that if in the center there are the adaptive mechanisms, in the extreme there are the pathological functionings, because a revolutionary model and the Kleinian model are no differences with normal and pathological functioning, are the same functioning, but with an extreme functioning, a distortion, a massive functioning, but the same structure of functioning. In the two models, there are the same idea. And we have the adaptive control in the extreme is obsessive functioning. The adaptive assertivity in the extreme is the paranoia. Adaptive withdrawal in the extreme is isolation. Adaptive self-criticism in the extreme is culpability. Paranoid depression in the Kleinian model. But in the other side of mental functioning, the side related to exploration, we have the confusional depression. It's different from dissociated depression. And we have the two different clinical forms of depression very well explained with this model. The paranoid depression related to culpability and confusional depression related to chaos or the bad functioning in the analysis of reality. And we can see in the center the adaptive functionings, and in the extreme with the same structure, mental structure, the pathological functioning. There are the same functioning with a massivity in the functioning of defenses, of mental mechanism, but with the same structure. We can see the adaptive rethinking in the extreme confusional depression, the rest adaptive in the extreme passivity, exploration, adaptive exploration in the extreme disorganization, chaos, and adaptive action in the extreme dementia. This is the idea of this model. I think that is based in the evolutionary model and the Kleinian model. We can see now the application of this model to analysis of the grief of language in migration. The change in the language is a very, very important factor for the good functioning of migration. This is fundamental to change of language, but many people have difficulties in the learning of the new language. And we can see mechanisms related to this learning. For example, there are people with capacity to control, to organize the plenitude of language, but there are people with an obsessive functioning related to learning the language. Waiting to learn all the grammar by heart with all the exception is a bad planification, an obsessive planification, and is a very bad situation. They are the check, the no learning the new language. Or there are people that reject the new language with a paranoid functioning. But
Sorry to
people,
interrupt, doctor, but you're exceeding
sorry,
presentation time.
sorry,
Sorry to interrupt, but you're exceeding your presentation time.
how minutes? I don't understand.
You're exceeding your presentation time.
Vale, very well, very well. See, I finish this slide and I finish. There are an example of the application, very, very practical of the model related to learning for the new language in migration. We can see in this part the attitude to a passive refuse of the new language, the procrastination to the learning the new language. In the other part of the test, we can see the idea of blaming themselves for not learning the language, the culpability. Or in the other parts, I finish, in the other parts of the kayak test, we can see other attitudes related to learning the new language. And we can help the migrant or help the people to improve their mental functioning for to have best results in the adaptation. For example, we can see the maniac process in the learning of a language. He wants to learn the language perfectly in a week. It's impossible to learn a new language. And the result is the sake of this learning. But this is a show of the application of the model. And this is the idea. In the center, the adaptive functioning control, in the stream, the pathological functioning. And thank you very much for the attention. This is the idea of the kayak test based in the combination between Kleinian and evolutionary theories. Thank you for the attention. Thank you for the attention.
Aims to become the tool of choice for neurosurgeons and patients suffering from TBI and or serious stroke, governing brain injury and intracranial hypertension. Throat position on the brain after the compressive craniectomy. Severe brain trauma such as TBI is a social disease. It is estimated that between 1.7 and 3.8 million traumatic brain injuries occur each year. The high social and economic costs make it difficult to manage.
Sorry, but could you share your presentation because we can't see it?
Yeah, sorry. Just just a moment. Sorry. Well, give me 1 second. Okay, I put poster and drawings in chat.
Can you share it on your own screen? Is that possible?
Just a moment. Sorry for the inconvenience. I check my. I have a problem with my computer, so I put in the chat.
Okay, we can share it for you instead. Is that okay?
Yeah, because it's yeah. I sent my document on WhatsApp yesterday, and
That's fine. We can share it for you. Is that okay with you?
Okay.
All right, we can share.
Okay, perfect. Thank you so much. Sorry. Okay, so severe brain trauma such as TBI is a social disease. It is estimated between 1.7 and 3.8 million traumatic brain injury occur each year, and the high social and economic costs make it difficult to manage and reintegrate patients into society. How to manage such a disability emergency? This alone is not sufficient to guarantee the success of the surgery and the recovery of the patient suffering from TBI, as the risk of mortality and morbidity remains high. Therefore, it is necessary to monitor and treat brain tissues and implement timeline neuroprotective strategies. Galeno would offer the possibility to reduce the time spent in hospital, guarantee a safer and more careful neurosurgery. Everything that makes Galeno has theoretical properties suitable for facilitating neural regeneration and repair following damage. This helmet has the task of protection, treating, and monitor the pathophysiological progress of the lesion, integrating neurosurgery and technological progress. The objectives are reduce swelling, protect brain homeostasis, eliminate excess waste substances, for example, blood, transmit chemical and electrical signals, map every area of the brain moment by moment, deliver drugs directly into the site of injury using nanoparticles that travel in tubular structure. Galeno was designed as a 3D printed helmet in bioceramic and hydrogel, whose fishing net structure already carries out an initial compression on a brain in the herniation phase, as the material chosen for its construction can offer support physics appropriate to the site of the injury. These materials represent the skeleton of the medical device, which is composed of an external part made of ceramic 3D printed and an internal part adherent to the brain parenchyma in hydrogel 3D printed. The combination of two polymers allows the creation of a medical device capable of imitating the physiological environment of neural tissue, which does not damage nervous structure and promotes the containment of swelling and the reduction of inflammation. Newly developed bioceramic have ceramic strength but metallic ductility. They are waterproof, resistant, and do not interact with the electronic components of the device. Hydrogel can be integrated to possess mechanical and physiological properties similar to those of the brain. They are also optimal candidates as carriers in drug delivery. They transport them to the target site by realized TEM at the controlled rate, both in time and space. They improve the accuracy of assignment with fewer side effects. The helmet is equipped with sensors that function as true navigators, sensitive to change in blood composition and pressure, temperature, and source of brain metabolism, etc. These sensors anchored one side to the internal interface of the helmet on the hydrogel sheet, and on the other side they deepen into neural tissue. The arrangement is designed to cover the entire surface of the brain. The special feature is the moment the sensor detects a change parameters, even a minor one, thanks to the near-infrared coating of the medical device equipment. Nice. With which they are equipped, the light up indicating to neurosurgeon where intervention is needed and being connected to a wireless transmitter that detects signals are reached via an electronic board. Near-infrared coating of the medical device equipment is an ultra-luminous and stable biocompatible fluorescent coating that can coat neurosurgical or surgical device of any materials. It is sensitized by combining a biocompatible polymethylene methacrylate PMMA polymer with a series of fluorescent dyes from the theanine 7.5 family. In the case of thread-based helmet, apply the sensor using theanine 5.5 as a donor on one strand and sign 7.5 as an acceptor of the complementary strand. It is possible to detect the characterize the NA-kappa-B transcription factor P50. Once the information is acquired through an integration process, it's sent to an external monitor screen placed in front of the neurosurgeon. Neural network in the brain must satisfy two fundamental organizational principles, functional segregation and integration, allowing both the repeated extension of information and the generation of coherent brain states. There is strong link between dramatic change in functional connective and TBIs, with recent studies showing change in correlation between neural networks during all phases, subacute, acute, or chronic, and all levels, mild, moderate, and severe of the injury. TBI has been classified as hyperconnective syndrome because the reaction that is triggered in response to the decreased efficiency of neural network is an increased level of connective, and it is why brain-computer interface, BCI, can be an important tool to assist the level of damage, supporting diagnosis and therapy. One innovative approach is to apply a file neural network via brain organoids and external microelectronics in order to prevent memory loss patients with TBI. Galeno uses a bidirectional interface that combines the direct reception of information that derives from brain activity with a return line that allows the exchange of information between the device and the brain. The tubular structure or canals that give the helmet its shape allow the brain surface to be divided into quadrants. These structures are made like the rest of the device with 3D printed biomaterials, for example, silk. Nanoparticles are ideal vehicles for drugs that can encapsulate within the particle or directly realize on the brain surface by absorption or binding with the polymer itself. They represent a powerful carrier as they can protect the drug from biological and chemical degradation, implementing its enormous potential to increase bioavailability. Polymeric nanoparticles can cross the blood-brain barrier intact or damaged, provide control through realized targeting capable and prolonged drug action via protection from proteases. In addition, by tailoring the molecular interaction between the hydrogel polymer network and drugs, covalent bonding, electrostatic interaction, and hydrophobic interaction, the drug release rate can be efficiently optimized. This helmet is bordered by an outflow system in which the pump is double action. The piston performs work on both the inward and return stroke. This type of pump offers great flexibility in design, variety of size, etc. Sensor can be included to monitor speed, temperature, pressure, vacuum. The combination of these results in a long-lasting fluid section system. Being equipped with an unidirectional circuit, the drained fluid does not flow back as the emptying bag is equipped with an anti-backflow valve. All this is made possible according to media thanks to finally regulated and integrated work of structure that work in series and pattern. I also believe that Galeno can be a valid ally in research. Potentially, the solution can also be extended to space, military, and neuroscience research. Thank you for your attention. And in my poster and drawings, do you need more information about this project? And I write my email in the chat for any question.
After all, success depends not only on the right treatment, but on the goals to reach. The goal of recovery is much more attractive than maintaining an illness the whole life, including a stigma issue. Those are quotes from some article. Consider a recent meta-analysis. 46% of depression patients and up to 57% of bipolar patients reported childhood maltreatment, including high level of abuse and neglect. Since data shifts our focus from only asking, what medication should we use, and examining disrupted neural pathways to asking what steps we can take to prevent disorders like bipolar disorders and depression. This evidence calls for a holistic approach that acknowledges early trauma as a significant factor. When the U.S. mental health classification system was the last revised, a group of clinicians proposed including early developmental trauma in the diagnostic criteria for mental health disorders. This approach would focus on trauma as a causative factor, but it was rejected, perhaps because it wasn't profitable for insurance and pharmaceutical industries. Yet, we find ourselves in the era where attitude towards mental illness are changing. Treatment models based solely on diagnosis and medication can no longer be relied upon to create significant impact. In nearly 40-50% of cases, treatment-resistant depression and bipolar affective disorder can be traced to childhood abuse or neglect. While both psychologists and doctors are aware of this link, psychiatry has traditionally emphasized biochemical failure over trauma. Now, some psychiatrists are advocating that trauma, particularly the long-term effect of childhood violence and neglect, should be included in the diagnosis. They even suggest that findings should be directed to address social issues rather than only developing new medications. This could be a revolutionary shift in mental health care. In my view, it's not only early traumas that can spark these disorders. Psychological trauma at any stage of life can act as a trigger. My perspective is different from the mainstream and shaped by my personal experience with bipolar disorder, witnessing my daughter's struggle and 20 years of working with psychiatric patients. Working in a non-professional position has freed me from the constraints of established theoretical knowledge, allowing me to view clients beyond their diagnosis. I followed a single guiding principle: do no harm. If something I tried worked, we continued. If it didn't, we moved on to work on something else. Most of my colleagues who strictly adhered to the diagnostic criteria missed opportunity to explore other helpful ways. Treatment approaches are frequently bound to protocols, with medication being the primary focus, dealing with different conditions and behaviors. even when patients experience significant physical side effects. Other approaches are often considered optional or secondary, which I find frustrating. The professional community often rely on statistic evidence, but the result of such studies are typically shaped by their intended outcome. Since there has been no focus on full recovery from bipolar disorder, no statistics would exist. This is reminiscent of the debate on homeopathy. Clinical trials often do not follow the homeopathic principle of individual remedy selection, treating the person rather than the disease, which homeopath argues renders these trials ineffective. I've consulted numerous specialists over the years, always asking, can you treat me as a person with bipolar disorder rather than focusing only on the bipolar diagnosis? My belief is that bipolar is a psychological problem when people's psychic are trying to adjust to real life circumstances. So medication should only assist that healing process. It's possible to be free from bipolar disorder if to take it under own control. My story offers a glimpse into why I believe recovery from bipolar disorder is possible when viewed as a psychological challenge rather than a lifelong illness which requires medication. I was born amid the breakdown of my mother's marriage and an intended second child. My birth was not welcomed. I was the product of an unsuccessful abortion. Though my mother provided for me a brother physically, she often lamented that her two tails prevented her from moving forward in life. So I grew up feeling unwanted as a burden. She eventually remarried, but her new husband became her priority, someone she always emphasizes as more important than children. Mother's negative feelings towards her ex-husband, my father, spilled over into me, leading to constant comparisons and criticism. This fostered deep insecurity, depression, and suicidal thoughts that eventually led her putting me institutionalized. There I was treated with aminazine, insulin comas, and sulfazine, which triggered manic symptoms. So began my 33-year battle with bipolar mood swings, fueled by medication and exacerbated by a lack of understanding. As a physician, my mother believed in medication and considered them the only solution for me, never seeing the psychological wounds beneath. Our relationship with my mother mirrored the swings of my bipolar disorder. During manic episodes, I would distance myself from her and couldn't even call her mother, while in depressive states, I was filled with guilt and would try to please her. She only accepted me during these depressive slows, rejecting in manias or hypomanias period, reinforcing a painful cycle, then went ignored. Physically, mania brought severe insomnia, irritability, racing thoughts, excessive talking, and sociability. Depression robbed me of memory, focus, sleep, and appetite, reshaping my personal traits. I had no psychotic or violent episodes except once, which happened in the hospital by the reaction to a sleeping pill, which caused me to misinterpret an innocent person's intention. Living in the former Soviet Union meant that information on mental health was sparse. I didn't recognize bipolar disorder as an illness, but rather as a mystery that needed understanding and correction. I managed to complete my education, get married, have a daughter, divorced, and moved to United States. But no matter where I went, the focus remained on medications. I wanted a different thing, understanding of what is going on. Often, before depressive episode came, they were preceded by special dreams, where people found themselves in a dead-end situation. Eventually, everybody could find a way out, but not me. Upon waking, I felt relief, but that relief was temporary, as the feeling of being trapped was in a real life as well. Once those dreams started after the depression just was over, it was strange. I reached out to Henry Reed, a dream specialist from Edgar Cayce organization where I had volunteered. I've learned that Henry managed to overcome his own bipolar disorder with ideas of Carl Jung. Those ideas had inspired me, and they showed the way to recovery. Although Henry lived in another state, he agreed to work with me. I learned to use email for our communication, and through his guidance and Carl Jung's ideas, I began to confront my bipolar disorder with insights and new tools. My daughter's attitude and our close relationship during 7 years together in a foreign country provided a healing force that counterbalanced my mother's attitude. My daughter accepted me regardless of my state, something my mother could never do. She supported me during depressive times, considering it as an illness trying to help. Before I tried to combine opposite sides and create the common one from them, always being the same, but it did not work. Working with a psychologist, we addressed mania and depression separately, simultaneously using healing techniques such as medication and yoga. Slowly, the intense symptoms subsided and eventually disappeared. The sleepless nights ended, irritability faded, and the long-lasting depressions became short periods of low mood, with mania transforming into manageable period of inspiration. The fear of my life being managed by something unknown disappeared. However, I had nobody to share my results. As my daughter got married and moved away, relatives got involved in her life. They spoke of me in a way that conflicted with the years we had shared, confusing her deeply. In spite of my disorder, we developed a close relationship based on mutual support and understanding. She was attached to me and felt stable and protective. Contrary to my mother, she was okay with manic times and saw depression as illness, trying to help me to cope with that. Under the influence of relatives, and especially her husband, who was against our communication, the daughter's psyche became split, and she started to have depressions, and eventually got into a manic episode. Doctors attributed her condition to genetics, and convenient explanations that ignored the stresses she faced from this relative's influence in our own family history of unresolved traumas. While I was trying to show her that recovery was possible, my family saw my success with the illness and a sign of ongoing illness, and even that illness transformed it into some more complicated type. They tried to keep my daughter away from me, referring to my bipolar disorder. At some point, her husband accused me of not giving my daughter's medication and hiding her from the doctors, and took away her small son, who had to be returned through the court. All his accusations were false, but when a person has a psychiatric disease, the attitude to the person's words are different. I observe it a lot at my workplaces. This is one of the reasons that people are afraid to get a professional help to avoid future stigma and attitude. In this vulnerable state, my daughter sought help from a psychologist who, instead of promoting resolution of existing problems, reinforced a narrative of separation. This psychologist echoed the familiar "my husband is more important than a mother" and cast me as a controlling, manipulative person, interpreting my deeds according to his psychological goals behind my back. As a solution, he suggested decreasing communication in the name of her independence. Naturally, my son-in-law took advantage of the situation and eventually forbade me to communicate with my daughter and grandchildren. Following the recommendations of separation specialists, my daughter rejected me as a mother without even talking to me. I found out about it only by accident. Is it a healthy way to deal with problems? Considering, of course, a genetic component, I still think my daughter's bipolar was triggered by trauma from relatives' attitude, including her mentality. She lived with my condition for many years, and nothing like that happened to her. Looking at things from a psychological point of view, I don't think it was a healthy idea to destroy the positive and reliable image of mother she grew up with and push on her some kind of mother monster instead. For a person's mentality, it is a serious trauma. So it's natural that by this way the trauma is getting inside and does destructive work there. The solution was, of course, medication, destroying my daughter's physical health, and the usual bipolar circles started to be. Our communication was forbidden as harmful for my daughter's health. I think the stable condition of my daughter living next to me was the way we handled the life issues, discussing with her most of them openly and equally, and resolving the conflicts to mutual satisfaction. This way, we both did not accumulate any traumas from each other in our life. But then she got more work with psychologists, bringing up child traumas, which of course was not beneficial to her health, only bringing more frustration to her condition. And of course, I remain with my own open wound. Something is obviously wrong with that approach. When I realized that nothing could be done to improve that situation, as a lot of forces were against that and no way I could influence the issue officially, I decided to close the problem in a peaceful way, as we usually solve conflicts living with my daughter, and then disappear from her life till something would change for the better. We drove to them to another state before Christmas with gifts and sweets, without any warning of arrival, thus violating the prohibition of my son-in-law. I found my daughter in a deep depression. She repeated statements of commercial psychologists on the separation issue. I used to be able to alleviate her depression and sometimes even reverse the condition by just talking to her. We started to communicate, but soon her husband returned, interrupting our peaceful connection, furious that a picture perfect he created but removing a sick relative was not perfect. He was very angry and demanded that she could go inside. He told my companion that I have bipolar disorder and he could not allow me to be around his family. Of course, I was worried about leaving the daughter in such condition, trying to figure out how things were, asking other people help as my phone number was blocked. Then I got a call from police officer talking to me as if I was a criminal, who warned me that if I would contact my daughter again, even to wish her Happy New Year, I could be arrested. The reason for his attitude was the fact that I had bipolar disorder and was not taking medications. So the disease by default means that a person is dangerous. Solution, of course, medication. But that time I had already completely figured out the essence of my disorder by observing what was affecting my emotional state, thoughts, and behavior, and it was completely under my control. Relatives reacted to that news, attributing my declaration about recovery to schizophrenia. I wanted to organize a forcible treatment. On my workplaces, it was obvious that most our clients' conditions were a result of their upbringing and living environment and continued being affected by labeled attitude. Then I decided to check my mental health officially. It turned out to be a complicated, almost impossible matter. All specialists asked why I needed it, why physical health can be checked just for the sake of health. For checking mental health, reasons are important. It is clear that the result would be related to my reasoning. I could not tell the truth, and I am a bad liar. And of course, I could not mention bipolar disorder. Those are words of some professional. You should not treat mental disorders diagnosis in the same way as a physical disorders diagnosis. With the body disorders are confirmed objectively, instrumentally, chemical and physical analysis. There is no serious discrepancy in the concept of normal and pathology. In mental disorders, there are a lot of contradictory, subjective, approximate, expert. There is no objective diagnosis method. Therefore, such a discord in the concepts of norm pathology much differ in different psychotherapeutical schools. I went to many specialists trying to find out at least some basic criterions of judgment for psychiatric issues, but did not get any. So in a person susceptible to disease, together with illness, dealing with the problem of negative attitude and manipulation of those who could be beneficial from that. I no longer have bipolar disorder despite a traumatic life situation. I don't have any symptoms, but have stigma which significantly affect my life, defining it, and nothing can be done about that. When in college, I asked a psychology professor, what is primary in depression? Chemical changes or depressive thoughts? She could not answer. I figured it out for myself, carefully observing what was going on with my mood, my thoughts, and how it manifested itself in the body. I came to conclusions that thoughts come first. This realization has become my tool for managing my condition. Just as lifting weights can bring a sore back, the same way certain thought patterns can affect mood swings. If you ignore those thoughts, then the body would start to react accordingly and chemical changes in the body would start. However, specialists usually treat the disease, the symptoms, not what creates them. I found no understanding from either psychiatrists or psychologists. Once experimenting with medication, I visited a psychologist and psychiatrist at the same evening. The psychiatrist said that I got out of depression. I have to start medication, preventing a manic state. He started to explain how violent people could be in a mania, ignoring my objection that I knew my disorder. Then I visited a psychologist who detected depression. I asked him how he figured it out. He said by observing my body language. In reality, I had neither at that particular time. Trying to clarify the issue, I entered a psychological forum hoping to find a theoretical explanation for my recovery from bipolar disorder. Specialists insisted on remission and refused to discuss recovery. They insisted that I should be satisfied with remission, while I argued that although I could still experience depression episodes like any other person, it would no longer be bipolar depression. I asked psychiatrists for their opinion on the issue of heredity, but they themselves were not sure and sent me to genetics. Nobody knew for sure and pointed to statistics. One of them wrote, "There is no such a rule yet. We are not supposed to consider recovery. That's all." Interesting that a statement about recovery was interpreted by professionals as a symptom of mania. They argued that a truly recovered person would not talk about their former diagnosis, much less challenge the idea of permanent remission. Even my reasoning for that did not change their opinion. Still, recovery and remission have different meanings, but nobody was willing to discuss that. I also learned from experts. Although the exact cause of bipolar disorder is unknown, they are not in a hurry to declare the curable, but only manageable, mainly with medications. As proof, they cite the statistics. But what statistic can be if recovery is not only envisioned, but not even discussed? Patients who seek help are likely to receive the same limited treatment as the stigma ensured that they remain labeled for life. One psychologist refusing to help me wrote, "No one will help you because you want to leave professionals out of job, but it's just the opposite." If it were stated that bipolar disorder is a psychological problem and medication should only help with symptoms, this would actually increase the need for competent psychologists who would have to take on the more complex job of working with a person, not just the symptoms of diagnosis. If this could be changed, I think everybody would be better off for it. There would be no more problem like life sentence for a person with disease, stigma and attitude, the opportunity to manipulate people with diagnosis. People would be more willing to get treatment, believing it's curable. Professionals would have different attitude. Maybe the pharmaceutical industry would suffer, but they would do something different instead. The World Health Organization conceptualized mental health as a state of well-being in which the individual realizes he or her own abilities, can cope with the normal stress of life, can work productively and fruitfully, and is able to make a contribution to his or her community. I believe I do all of that, but cannot claim mental health because the stigma attached, including the element of being a danger to society, as having untreatable disease and not using the official treatment. Perhaps the definition of mental illness should be defined as danger to society as term of stigma attached, or the term of normality should be changed. Big danger to others and mental illness are not the equal things. Why I have managed to find stability in my life, it has come to the cost of relationships and once brought me to so much positive energy. The story of my journey with bipolar disorder shows how the recovery is possible when the illness is treated as a complex psychological issue, shaped by human experiences and relationships, not merely as a biochemical disorder to be medicated into submission.
clinical direction should we take in the future? But first of all, allow me to thank my research team, starting with Professor Vincenzo Provenzano, head of department, who was fundamental to this research. Dr. Mario Tambone Reyes was also crucial, because I have to say that without him I would never have been able to accomplish all that I have. Dr. Francesca Provenzano, internist. Dr. Davide Brancato, an international renowned endocrinologist of great importance. Sara Bazzano and Rosa Gesualdo, psychologist. Simona Marchese and Maria Luisa Savona, psychotherapists. What are we looking at this moment? We are observing that the SARS-CoV-2 pandemic, beyond disrupting the global healthcare system, has revealed by its nature and complications a multifactorial complexity with very significant long-term consequences. In particular, and this is what we will discuss today, the alteration of the nervous system and how it is affected. This study aligns with other international studies analyzing the actual metabolic and neurocognitive alterations caused acutely and in the long term by COVID-19. The aim was to understand the correlation and emergence of comorbidities of the alteration of cognitive deficits, thyroid deficits, and gliatic alterations, and how these all presented regardless of the gender differences. On the other hand, this study attempted to show all the significant effects on the brain, identifying symptoms that, on a large scale, led to memory impairment, attention deficits, and even severe executive dysfunction. This approach, combined with neuroimaging technologies, analyzed how we can simultaneously talk about genuine cognitive, metabolic, and brain-wide alteration. So we focus on the relationship between metabolic health and cognition, proposing new paradigms for integrated patient management. Now I will introduce a slide that has gone global because I had the pleasure to present it at various congresses and explains in terms of pictures everything we want to talk about. As you know, these are the neuronal forms, neurons, astrocytes, microglia, oligodendrocytes. Well, the spike protein, thanks to H2 receptors, entered our brain and created microglia where it shouldn't, in the amygdala cortex, the olfactory bulb, the posterior cingulate cortex, and the substantia nigra. Neurologists in the audience will understand well what it means when we observed post-COVID alterations in the substantia nigra, the dorsomedial prefrontal cortex, the dorsal vagal complex, and the nucleus of vagal neurons. We certainly know that SARS-CoV-2 has altered the vascular system of the brain and the entire body. Neurotransmitters experienced a significant decrease or permanent increase during COVID phases, creating real damage to endothelial tissue. This has put the brain under immense stress because by crossing the blood-brain barrier, it disrupted the fundamental principles leading to NMDA receptor alterations and glutamate dysfunctions. What were the neurological
and physiological, psychological damages and complications of COVID-19 in the acute phase, and later we will also see in the long term. The estimated cumulative incidence of psychiatric manifestation concurrent with SARS-CoV in hospitalized patients is about 59%, including depression, post-traumatic stress disorder, panic disorder, and obsessive-compulsive disorder. The overall incidence of neurological complication has been reported in comprehensive studies to be about 37% in hospitalized patients. These complications were more common among severe cases associated with greater acute innate immune inflammatory response, higher levels of CRP, ferritin, and D-dimer. The symptoms included headaches, the well-known brain fog, encephalopathies, delusions, syncopes, and some cranial nerve dysfunctions, we can say culminating in Guillain-Barré syndrome. So we are gonna see what are the signs and symptoms observed in long COVID that are, for example, the brain fog, headache, the numbness, tingling, dysgeusia, anosmia, myalgia, dizziness, blurred vision, tinnitus, movement disorder, focal motor deficit, focal sensory deficit, dysarthria, ataxia, seizure, dysphagia, and aphasia. On the other side, there are more subtle symptoms, often linked to mild comorbidities, ultimately including cerebral dysfunction. So we can see fatigue, the depression, anxiety, insomnia, short-term memory deficit, attention deficit, and so on. The pathogenesis of COVID-19. Well, as you know, inflammation of the limbic system and hypothalamus has led to significant consequences. COVID has behaved as a severe stressor for these brain regions, causing external effects such as mood problem, anxiety, depression, fatigue, and malaise, sensory motor problems, cognitive issues, and blood-related dysfunctions like elevated cortisol levels and frequent urinary infections. Additionally, hypotension, so orthostatic intolerance, cardiovascular and gastrointestinal problems were frequent in both acute and long COVID, alongside sleep-wake cycle disruptions, circadian rhythm inversion, and significant thermoregulatory problems. So we see that thus COVID, as a severe stressor, caused hypothalamic and limbic system circuit alterations, astrocytic dysfunction, and neuroinflammation. This led to cognitive dysfunctions while also generating significant emotional and behavioral stress, as you can see in this scheme that shows the pathogenesis of long COVID. All these elements are schemed so we can follow. So, what are the mechanisms contributing to psychoneuropathology in long COVID? These 5 represent the temporal and symptomatic timeline of COVID: chronic viral infection, systemic inflammation, neuroinflammation, microvascular thrombosis and neurodegeneration, trauma, culminating in true comorbidity with cognitive impairments. In acute cases, these are the alterations we also found in long COVID. Many patients retained their olfactory and gustatory dysfunctions and did not recover. Memory disorder observed during the acute phase persisted 3 years later in some cases. While some showed slight improvements due to adaptation, of course, others maintained the same identical test scores. So, which structures unexpectedly showed microglia presence? As you can see, these include the anterior cingulate gyrus circuit, particularly the medial orbitofrontal area. In area 24, the red dots you can see indicated the glial presence, and it's where it should not be, extending to the internal rostromedial pallidum, ventral pallidum, ventral striatum, substantia nigra, and trauma areas. We also found it in the lateral orbifrontal cortex, which regulates emotions, including areas 10, 11, and 22, as well as the amygdala. Clinicians present in this room note the significance of microglial presence in the amygdala for emotion and behavior regulation. It was also found in the thalamus, external pallidum, and caudate nucleus, core structures triggering significant emotional and behavioral phenomena. Our study analyzed 245 patients split between males and females aged 35 to 70 who were hospitalized at Partinico Hospital in Sicily. The data we obtained aligns closely with the national findings, as we'll see in the next slide. The study aimed to examine brain alteration caused by COVID-19, including glial dysfunction and neuroanatomical damage. It explored the correlation between neuronal changes and cognitive deficits identified through standardized tests. We investigated the impact of chronic neuroinflammation on neurocognitive structures and executive dysfunctions. Additionally, we reviewed metabolic alteration data from other patients. Now we are entering the part where we will show the research phases, so we can analyze the objectives of the study with all the phases that we gone through. Here are the standardized tools we use. Neurological correlation were observed through neuroimaging, endemic alteration, and meta-analysis, focusing on glial presence in the hippocampus and temporal regions. The third phase involved cognitive rehabilitation for patients showing mild, moderate, or severe cognitive deficits based on testing. So, after all that, I want you to introduce the results. The results were not encouraging. 87% of patients had some form of cognitive impairment. 47 had mild deficits divided between men and women. 33% had moderate impairment, and severe deficits affected over 10%, nearly 11%. 24 of the sample has PTSD diagnosed according to DSM-5 with a significant correlation between post-traumatic symptoms and cognitive deficits. Among the PTSD group, 33% exhibited both cognitive deficits and post-traumatic syndrome, while the 20% experienced severe deficits comorbid with PTSD. So going on, what did the MRI reveal? Very interestingly, Scans showed that 51% of the sample had gliotic alterations, reflecting disrupted neuronal homeostasis regulation. Temporal lobe atrophy correlated with memory loss and recognition issues, while hippocampal reduction was linked to deficits in long-term and working memory. These findings are not encouraging at all. Many are now discussing of COVID dementia. Individuals showing this decline and cognitive impairment prevalence still exhibit persistent signs 3 years after initial evaluation. In women, milder deficits may be attributed to hormonal and behavioral factors. In contrast, men showed worse outcomes, likely due to higher hospitalization rates for diabetes. Microglial and astrocytic activation suggests ongoing neurodegenerative processes linked to COVID-19. Hence, we begin to speak of COVID dementia. That's why we're arriving here, and here I'll show you on an image that can be clear to show you what we are talking about. Here is Mr. Daniel. On the right, you can see a pre-COVID MRI showing normal condition with small glial plaque. On the left is brain 3 months after COVID infection, revealing its really deteriorated state, as you can see. So, conclusions. Maybe we may need to start discussing COVID dementia, requiring a multidimensional approach for these patients. And this includes comprehensive thalassological evaluations, brain imaging, significant metabolic monitoring, and immediate cognitive rehabilitation for patients showing any cognitive alteration through a targeted program for executive functions. As you know, the study is ongoing. Patients continue to be monitored. We hope to be wrong and not facing a COVID-related dementia crisis. After all that, I want to say that, of course, international collaborations are welcome, and that we await your findings to apply our protocol globally for answers to these challenges. At last, I want to thank you for your attention, and again, thank you for the invitation. Allow me to express gratitude to the research team. Thank you.
And you have a lesion there. So that's why it's called a pseudobulbar affect. So it can manifest either in 2 ways. One is either crying for no reason or laughing for no reason. So that's why it's called pathological laughing or pathological crying. And also sometimes that's also called emotional incontinence. So essential criteria, as we discussed. So mainly what they say is according to the books and according to the literature, there's no known cause, but they see that people keep crying for unknown reasons with no appropriate situation. So it can be stimulated by any non-specific stimuli. It could be stereotyped, meaning that they can be crying all the day sometimes. And also it's very difficult for the patients to control their emotions. And there's no close correlation between the patient's emotion expression and how he or she is feeling. So for example, let's assume that they might be having a good time, but still with no triggers, they can start crying. So or like can staff laughing without any joking. Even like sometimes there have been incidents where people would go for a death and suddenly start laughing for no reasons, and no sense of relief as the effects are expressed. So like even when they cry or when they laugh, the burden from their heart is not taken away. They still feel sad, and that makes them feel unhappy because they're doing inappropriate things with having an insight, meaning that they know that they're not supposed to do it, but unfortunately, because of the alignment in the brain, it comes out in a different way. Then what are the causes? So especially these are more neurological causes than psychological causes. Epilepsy, then traumatic brain injury, especially you get to see a lot of cases in traumatic brain injury, the neoplasms, especially astrocytoma, glioblastoma, you tend to see more of these cases. And also degenerative conditions like Alzheimer's, Parkinson's, and you also get to see in ALS, one of the common manifestation of pseudobulbar affect with ALS. And then MS, multiple sclerosis, can also cause this. So I also want to tell that there are two things like pseudobulbar palsy and pseudobulbar affect. The thing with pseudobulbar affect, it's just either you smile or you cry for no reason. But pseudobulbar palsy, sometimes you can have problems with the nerves, with the cranial nerves, especially you have problems with 9, 10, 11, and 12. The affect is just about either you're, I mean, like you're either laughing or crying for no reasons. Then the prevalence, especially in recent published studies, it says that I mean everything has high, but like as we discussed before, TPI. If you see TPI, it has 3% to 80% of presentation with either crying or laughing episodes. So pathophysiology of PBA. So there's no, I mean, we haven't found any particular real set of reasons for it. But they say that there's a disconnection between the alignment. So, for example, if you see this picture, you see that the frontal lobe, the motor cortex, the somatosensory cortex, and cerebellum aligned and make sure that they're modulating your behavior. So, what happens when you have TBA or when you have other neurological conditions is that there's disalignment. So what it means is sometimes what happens is like your glutamate, the proposed hypothesis is that your glutamate is increased and your GABA is decreased and also serotonin is decreased. So because of that, the brake is taken away from the motor cortex, and then either you cry or the effect is exacerbated. For example, like you laugh, you keep laughing, you cry, you keep crying. So we haven't found a real cause yet, but this is the hypothesis. Then because of that, like what happens is, I mean, if you don't identify early, what happens is that can lead to depression because they're doing things which they're not supposed to do and they have better insight. So having insight also makes them feel depressed. They feel anxious. For example, let's assume that they're going for a death and suddenly they feel anxious. What if I'm going to I mean, like, so if they're laughing all the time, and if they know that they're going to laugh with no reason, that's going to put them in an awkward position and let them not go back there. And also, we have seen that like there's social interactions, impaired social interaction and cognition because of all the consequences with the family. So I had a patient who came and said that, I don't know why, but I started having problems with my marital life and also sexual life. So it can lead to very bad consequences if it is not treated well or if it's not identified at the right time. And again, decreased quality of life. So I had a client who was a peer reviewer, peer coach reviewer, meaning that they deal with the addictions, especially if the patient tells about her simple problems, she keeps crying for hours and hours. So it took time for her to realize that it wasn't depression. So again, simple things like this can really fix and make their life more easy if we can give them diagnosis early and treat it early. Then differential diagnosis. So, patients come to us telling that they're depressed or they're anxious, PTSD sometimes, but mostly the common symptoms I have found is depression and anxiety. So I do behavioral neurology, so I get to see a lot of neurology cases. So in that aspect, I have seen patients who received TMS, who received ECT, and then later came and they had to be diagnosed with pseudobulbar affect. So, but it took them years. I mean, like also neurologists easily diagnose this because this happens to be their cup of tea. But sometimes what happens is they go to psychiatrists first because they have more episodes of crying and also more episodes of either laughing. So they think that something is wrong with their psychiatric issues, psychological problems, sorry. Then neurology, again, the differential diagnosis, always you need to have this under your list. And again, sometimes it's easy to differentiate from, sometimes it is it can be easily taken away with the diagnosis of depression. But this is the difference between depression and PBA. You see the length, it can occur in seconds to minutes, and whereas in depression, you have days to weeks, and control is a little bit more, and it can be easily regulated in depression, but whereas in PBA, sometimes they can, but most of the time they cannot. The effect is especially incongruent with PBA, whereas in depression, it's more congruent with your mood. Also, the behavior completely, I mean, they don't have any behavior change. It's just the crying episodes. Whereas in depression, I mean, it's very self-explanatory that they feel tired, apathetic, and sometimes they also get agitated. Then perceptions, there are no presentations or misperceptions here in PBA. But in depression, what you see is there are often misperceptions, negative view of self or others, right? The insight, usually, I mean, like you have very good insight in PBA, sometimes depression, it can be impaired. And then stimulus also is different, and it gets exaggerated, whereas in depression, only it gets exaggerated in a specific situation, and they have particular triggers for them to make for them to have crying episodes. But again, in the worst cases, they also can have crying episodes with no triggers. Any questions so far? Okay, so the treatment options here is like dextromethorphan quinidine is FDA approved. Then also we use off-label TCAs, then SSRIs, and also we have serotonin SNRIs, and then also memantine sometimes on counseling and education. So I'm going to present one of my cases so that it's going to help all of us to understand it better. So it's a 42-year-old female with psychiatric history presented to our outpatient behavioral health or crying episodes. The main symptoms, what we noticed is severe depressed mood. She said that she was having low energy levels, but emotional dysregulation, especially she was having all the crying spells with no triggers. So she kept crying even throughout the interview when we were trying to talk to her. So when we went into the past history, we have noted that she had astrocytoma grade 2, just removed 2 to 3 months ago before we saw her. And since then, what she noticed is she has decreased low energy levels and executive dysfunction, meaning that so your dorsolateral prefrontal cortex in your brain helps you to plan, execute, and also have sustained attention. So all that is lost. She is not able to plan. She is not able to pay attention to her clients, and she is having severe time having that sustained attention since she had the surgery. And she also had severe crying spells with no trigger since then. And also, she was seen by a neurologist, and she was put on Depakote 250 milligrams twice a day because she was having severe headaches after the surgery, and at the same time, she was given all other medications and had also also had migraine-like episodes since she had surgery. And also, it was helping her for prophylaxis of seizures because like first 3 years or sometimes first 6 months, especially, they say that it's very crucial for them not to have any seizure episodes. So they generally start them on prophylactic mood stabilizers. So that's what they have done, and there's no other particular prevailing history in her, no other medical conditions, and she was just but like before she came to us, before Depakote, she was tried on other medicines, but her headache wasn't being successful. So she was taking Depakote on a regular basis along with pain medicines as needed. Then we did this, we also did a PHQ-9, but I haven't put it here. PHQ-9 also was positive for mild to moderate depression, but like we did a PBA scale and she scored 21 out of 35, which indicates that she has a severe PBA. Anything above 13 indicates that she has PBA, but anything about 21 to 35 suggests that she has severe PBA symptoms. So she fell in the category of severe PBA. So again, she scored very high on everything, and we started her on New Dextra. So New Dextra is dextromethorphan with quinidine. So the quinidine doesn't play too much in this. It only helps in 2D6 inhibition. So, but like other than that, like quinidine doesn't help you in depression or anything else. It's just for blocking dextromethorphan. So we started her on low dose. So and then eventually increased the dose even before her first visit. So what she said is, in the first visit, she said that she got better and she's able to engage in her daily activities, but still it was interfering with her regular, with her at her work, sorry. So it was more interfering at her work rather than at home. Then she was maxed out on FDA regulated dose of New Dextra already by then, and we started giving her extra dose. So she was getting almost close to, the FDA approved dose is close to 40. She was getting around 50. And, but again, you know that insurance plays a vital role in this country. So insurance gave us a pushback stating that, we have already maxed out on the dose. And we also did a PBA scale on her. On her first visit, it was around 17. Then also, again, after we increased the dose in her second visit, already it means that what we did is we already maxed out the dose in the first visit, and then, in the initial visit, and then in the second visit, meaning that like in the follow-up visit, we gave her extra dose. And in her second follow-up visit, what we noticed is that her crying spells and executive function got better, but still she had ongoing crying episodes. And because of that, she felt helpless and depressed because she couldn't control her crying episodes when she went to work, which was really disabling her. Though she scored 14 on PBA scale, she was telling that she wasn't happy and also started having marital issues with her husband because of her sexual life, because like she was more preoccupied with crying episodes. And again, we discussed various options, and also because of the depression and executive dysfunction, we thought to start her on Avalti. So Avalti is one of the recent FDA medication. I'm thinking and I'm assuming that this would have also come in other countries. So it's a combination of dextromethorphan with Wellbutrin. And we discussed this, and she was okay to get started on it. So, but again, as you know, that Wellbutrin sometimes can cause seizures. Seizures were ruled out, and already she's on Depakote 250. So, but still, we want her about the seizure. And the good thing about Wellbutrin is it doesn't cause seizures. It only decreases the threshold of seizures when you go above 300. And like in this dose, the max dose is 220. The good thing about this medicine, because it starts off with 45 and you can go up to 90. So that's the best thing about dextromethorphan. So dextromethorphan component in this preparation. So we started Avalti. So the max dose we could go up to Avalti is 90 milligrams. So we just wanted to see how she was doing. So I asked her to take 1 tablet a day for 3 days, and then following to increase to twice a day. So she started off with Avalti once a day for first 3 days. Then she increased it to twice a day. Then she came to the third visit. So when she came to the third visit, she said that things got so much better. Right now, she has crying episodes, but very rarely. And also, she said that it had to be triggered now. It's not that like she's getting crying episodes with no triggers. And also her executive function got better again, as I said. So I didn't say this, sorry. So, but Wellbutrin also helps with your executive functions, meaning that it helps with your attention, concentration, and also it helps with your with your planning. So we call it as SOAP. So generally, your dorsolateral prefrontal cortex helps with your execution, then helps with your sequencing, helps with planning, also helps with abstract thinking. So, but she was able to plan, she was able to execute all the things the way she wanted. And she felt that she almost came back to her pre-morbid condition, but she said that she was so happy that she's able to do her chores at home and work at her job very well. And her PBS score came down to 10. So this is so this is the comparison. Sorry. Yeah, this is the comparison between her first visit and the recent previous visit. So it's 10. If you see the boxes, the score have drastically gone down, and she's doing much better with Ovaltine. And with Ovaltine, that is a combination of dextromethorphan with Wellbutrin. Again, there have been very good studies that a lot of PBA could be treated with antidepressants, and especially they tried Prozac. Prozac is also 2D6 blocker. So they used to give Dudextra with Prozac so that the efficacy could have gone up. But in this case, we didn't want to give too many medicines, and also sometimes Prozac can inhibit too strongly. So that's why we chose this medicine, Avalti, so that it could help with the depression executive function, especially the reason is, again, it's a weight neutral. And only the downside is a lot of people are worried about seizure. But again, as I said, seizure is not, it doesn't cause seizures, it only decreases the threshold. We also got her CMP levels, and she didn't have any eating disorder. So all those were ruled out. I didn't put all that in this, but yeah, we ruled out all that just before we started her on Avaltine. But again, we have very, very good studies about the medications. I think I skipped that slide. Yeah, no, I didn't. So yeah, we also can try memantine if needed, and we can also try TCA. But mostly, I'm not a big fan of TCA. And if I have to choose medicines from TCAs, I would choose nortriptyline or not imipramine, the sister drug of imipramine. It's not coming to mind right now, but those would be the better options because they have less anticholinergic side effects. Again, already quinidine can give anticholinergic, and if you're going to add more anticholinergic problems, that would be a burden for the patient. And also counseling is other important thing we need to do, and we need to educate not only the patient but also the family about the importance of PBA and the consequences associated with it. I think that's it. Any questions or any concerns about this? Hello? Hello?
Yeah, hello, doctor.
Can you hear me?